Hi, Jackie. I see you've joined us. Would you like to do a microphone test?
Yes, sir. Good afternoon.
Good afternoon. Thank you.
Thank you.
And Jeff, I see you've joined us as well.
It's Jeff. Thank you for checking in on me.
All right. Thank you. Hi, Miguel. I see you've joined us. Would you like to do a microphone test? Is your audio connected yet? Okay, Miguel, I think you've joined us. I think your audio is connected. Are you there?
Yes, I am here. Good afternoon.
Good afternoon. Thank you very much. Supervisor Lee, I see you've joined us as well. Would you like to do a microphone test?
Yes, can you hear me?
I can hear you. Thank you very much.
Great, thank you.
And Dr. Cody, I see you've joined us. Would you like to do a microphone test?
I'm here. Can you hear me okay?
I can hear you. Thank you very much.
Great. The only thing I'm not confident about is sharing slides, which is still a skill in progress. I'm going to try to get someone to help, but do you have a backup idea?
Yeah, if something goes wrong or it won't work, I can pull it up from over here and I'll try to keep along if need be.
Thank you very much.
No problem.
Recording in progress.
And Supervisor Smitty, and I see you've joined us as well.
I have.
Thank you very much. I can see you and I can hear you.
All right, then let's begin the meeting, everyone. This is Santa Clara County Board of Supervisors committee hearing for our Health and Hospital Committee. The first item of business, of course, is to simply call the roll as we call the meeting to order and establish the presence of the quorum. So let me ask the clerk to call the roll and establish the presence of a quorum, please.
Vice Chairperson Lee.
Lee is present.
Thank you. Chairperson Smithian.
Here.
Thank you.
All right. Both members are present and accounted for. That takes us to item number 2, which is public comment. And public comment, folks, is that portion of our agenda set aside for comment on non-agendized items. Again, this is for comment on items that are not on our agenda, but that are properly within the jurisdiction of our committee. So I want to ask people again, if you want to speak to an item on the agenda, please do so at the appropriate time. And if this is an item of interest to you, but not part of the Health and Hospital Committee's portfolio, this is not the time or place, I'm afraid. All right, let's see. Do we have folks who want to speak under public comment, Mr. Clerk?
There's currently one request.
All right, let's go ahead and hear from that person, Madam Clerk, and we will give that person up to 3 minutes.
Thank you. Our first speaker is Joe Den. I've unmuted you. Please accept the unmute. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Hi, my name is Joe Dean. Hold on, now I've unmuted. I've lost my my notes here. There we go. I'm Joe Dean. I'm a resident of Sunnyvale and Vice President of the Santa Clara Valley Square Dancers Association. I'm here to ask that Santa Clara County adopt a modified masking policy for fully vaccinated stable cohorts, as several other counties in the Bay Area have already done. Our member clubs are already limiting participation in their classes and dances to people who have been fully vaccinated against COVID-19. Most square dance clubs in this area adopted that policy on their own without waiting for any kind of government mandate when they started meeting again earlier this year, even the ones that started by dancing outdoors, because they found that this is what their members preferred to be able to feel safe. No unvaccinated person could catch the virus at one of our events if we weren't wearing masks, and none of our members can catch the virus from an unvaccinated person even if they aren't wearing a mask, because we are not allowing any unvaccinated people into our events. If it is an epidemic of the unvaccinated that is putting extra load on our hospitals, requiring people at events like ours to wear masks is not going to have any significant effect in reducing that load. The key to reducing the load on our hospitals and improving the public health situation more generally is supposedly to get a higher fraction of the population vaccinated. But we can't help you with that because we are all already vaccinated. We've already done that. Taking no account of vaccination status in setting your masking policy also strikes me as a serious missed opportunity if you actually want to encourage more people to get the vaccination. Our clubs are now suffering attendance loss because there are many dancers simply are not comfortable dancing with a mask or outdoors, which is the only alternative currently allowed. And those that feel forced to take the outdoor approach will suffer increasing health risks as the weather gets colder and wetter. Lifting the mask requirement for situations like ours is a sensible policy that could help not only our groups, but many other nonprofit organizations, as well as certain kinds of business situations. If San Francisco, Marin, and Contra Costa counties can all do this, we should be able to do it here in Santa Clara County also. Thank you for your time.
Thank you, Mr. Dean. And while we do not typically respond to comments from our public comment period, I do want to share with you that the decision that you are addressing is one that necessarily and by virtue of state statute comes from and through our public health director, Dr. Cody. In our case, I don't know if Dr. Cody is on the call and heard your comments or not. If she did, I would ask you just to lean in and say, I heard the call. And if not, because I know we will hear from her later, Dr. Cody, go right ahead. Excuse me.
Yes, I did hear, just acknowledging. Sorry, I had a hard time coming off.
Thank you. Sorry to put you on the spot like that. I just wanted Mr. Dean to know that Dr. Cody and her public health department are responsible for weighing all the various factors, and wanted you to know that your message had in fact been heard by the appropriate party. So thank you again for sharing it with and through the committee. Let me just confirm with the clerk that that was our only speaker under public comment today.
I do have 3 more hands up.
Okay, then we're going to cut it off there, please. Let's go ahead and hear from the next 3.
Okay, our next speaker is Tino. I've unmuted you. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Yeah, I'll make this pretty quick. I see on the agenda that there is a special meeting on Tuesday, October 26th at 2:30 p.m. in the Board of Supervisors chambers. I know you just said that you don't typically respond to public comment, but I'm curious about something and I hope you make an exception. Will the public be allowed to attend in person Tuesday, October 26th at that special meeting? And why is the special meeting being scheduled? That's all I have.
Sure. And just to let's go ahead and provide a little clarification here. Just to clarify, notwithstanding the way the meeting has been noticed, it will in fact be a virtual meeting, just as this one is being conducted as a virtual meeting. The public will, of course, be able to attend/participate. The one change in our typical agenda structure, however, is that in order to accommodate the schedule and the participation of panelists from a range of areas, we will start with the panelists. We will have back and forth with the 2 committee members, Supervisor Lee and myself, and public comment both on the item and more generally will be held until the end at approximately 4 o'clock, an hour and a half into the hearing. But again, it will be a virtual hearing pursuant to the rules adopted by the state of California and our Board of Supervisors, just as today's meeting is being conducted. Let's go on to our next public commenter.
Our next speaker is Scott Largent. I've unmuted you. You'll have 3 minutes to speak. Please go ahead.
Thank you, everyone. Scott Largent. I am curious why nobody from behavioral health or the health department, I guess in general, is not showing up out to Spring Street. I try to wave the flag a lot on what's going on out there, but when you stack several different zones into one area, it just doesn't seem right from a mental health standpoint, and also from the fact that I do believe we're still in a pandemic. I know things are going well here in Santa Clara County, but it just doesn't seem right. I've asked over and over again, and I'm just kind of puzzled. Every once in a while, I see a county vehicle, a van, with the logo on the side of it. I don't know if they need a tour guide. I don't know if they need somebody to accompany them to know the proper places to go. I just don't understand it. We can't just keep looking the other direction on what's going on. Yesterday, there was of course, a San Jose City Council meeting, and it went on for about 2 hours and 45 minutes about the crash zone and what they were planning on doing and putting up fences. And, you know, a lot of the politicians, I truly believe they're just playing stupid. And I think they know exactly what's going on. You cannot miss the humanitarian disaster right there. And it's just very strange. It's like they're coming to the table a little late and acting like they really care about people out there and safe parking programs and adequate shelter and care. Most of that stuff is not even available right now. When I contacted the shelter hotline, it took a little while to finally get a placement, and it was a bunk bed at the Picardo little torture shelter over there. And during COVID, I don't think stacking bunk beds is appropriate either. The shelter that you guys have functioning right now out at the fairgrounds had a big outbreak of COVID. And as they continue to call me back, they say there's no way we can place you yet because we're still dealing with that. It just all seems wrong. It just doesn't, I mean, it doesn't seem right. People don't have a place to go, and they've sandwiched them all together. And I'm not going to beg. Several of you elected officials have already driven out there. You've been responding back and forth with me. You see what's going on. And I just asked for maybe our health department to get involved. Maybe Dr. Cody can go for a drive down the street out there. Because once you see it, then you're just amazed. These people really, really, really need help. And especially with this storm coming, you guys can't keep looking the other direction. You really can't. Thank you.
Thank you. And I believe, Madam Clerk, we have one more speaker under public comment. Yes, no?
That's correct.
Go right ahead.
Our next speaker is Carlton Allen. You'll have 3 minutes to speak. Please go ahead.
Hi, good afternoon. Supervisors, I did speak yesterday. I just wanted to finish up on the issues that I see about the sheriff's office and bring up one more issue. With the sheriff's office as proposed, I still really am trying to figure out who came up with this proposal. Under the penal code of a sheriff's security officer, the sheriff can decide to give these people weapons and decide that whatever she wants to do, or he, if we get a new sheriff, can dictate how these people function. There is many issues with her and her style of leadership. The fact that they would have to do polygraph tests would even farther limit our ability to hire. And at this point, the department still has yet to be able to fulfill the positions. Also, in the proposal that we received, they didn't even take into account the 2 new hospitals that we have. In past contract negotiations, we've made it very clear to labor relations that these gentlemen at our hospitals that work, and women that work in our facilities at the hospitals, need and have a higher level of training than do this security, the PSOs at social services. And that has not been addressed even in this iteration of a reclass. They did a study before and the ESA threw it out. And then in this time, they take the same study and just change it and add in, now they're going to be under the sheriff's office. So I still say, if we're going to give this woman more money, then let's not ask for her to be investigated. Let's just give her more money and let her do whatever she wants to do. And we'll just be looking at lawsuits down the road. The other issue that I wanted to bring up is how we're doing the exemptions. I want to make clear, I am for a mandate. But when we walk out and we're just doing things haphazard, they're now saying people that are unvaccinated, they created 3 levels of how these people are supposed to be, their exemptions are going to function. Some people may not have a job in a couple of weeks or next week because we only have 11 days to get people and figure things out. and it's all rushed. No, it's not talked through. And then labor relations and ESA are giving us different answers for different unions. They need to stop and be clear and be more transparent, because it's only hurting our community, our staff, and our patients. And I'm just like mind boggled how they're functioning with this. I thank you guys for your time.
That concludes our requests.
Thank you very much. That takes us to item number 3, which is to approve the consent calendar and any changes to our published committee agenda. Supervisor Lee, would you like to make a motion in connection with our consent calendar?
Yes, I'll be happy to. Actually, I have one item I would like to see if we could also add to consent, which is item number 11, regarding the FAF report on the status of the Valley Medical Center Master Plan. Want to see if this is something you would be interested to add to consent as well.
Happy to do that. I think we could also add item number 5, which is the monthly report on the Behavioral Health Services Center and Adolescent Psychiatric Facility.
Right.
If you're amenable, item 9B and C, does that work for you as well?
9B is behavioral health relating to call center merger and the OT costs, and C is relating to improved access to individuals on jail assessment coordinator list. And yes, those looks fine with me as well. Okay.
All right.
We have a correct.
Go ahead, sir.
Yes, I'll go and make a motion to put 5, 9B, 9C, and 11 onto consent.
All right. So we have a motion, which I will second, from Supervisor Lee to approve the consent calendar and agenda as contained in our published agenda, but with the addition of 5, 9B, 9C, and 11 for the record. I have seconded. Let me check with the clerk to see if there are any speakers on the consent calendar item.
I have one request.
Go right ahead, and that person will have up to 2 minutes.
Thank you. Our first speaker is Scott Largent. I've unmuted you. You'll have 2 minutes to speak. Please go ahead.
Thank you. Good afternoon, everyone. Scott Largent. I understand you guys got a busy meeting today, so I'm not trying to chew up too much time. What I'm getting at right now is the behavioral health issues, the items that have been thrown on consent. I know how the process works. I know you guys got to get through this meeting. I keep bringing up why they're not showing up. And for such a long time of attending these meetings, all of you have kind of really been lighting that fire underneath our behavioral health system. I'm just trying to explain what I see. I live in an RV down the street from your county building. I constantly watch people in traffic. I watch them screaming, yelling, butt naked, smoking meth, doing the most bizarre stuff in the world. I watch law enforcement just drive right past these people like it's normal. This is not normal behavior. A woman the other day, she had a traffic cone on her head. She had another one that she was using as a shoe. Half of her clothes were on, which was so bizarre. It was like the left side. I don't know if it was a brain disorder or the methamphetamines that was doing it. Like all the people that I talk about, it just continues. It continues and it continues. This has to stop sooner than later. These people need adequate care. They need a place to go, and they should not. Well, our psych ward should not be a 66-acre field in front of the San Jose International Airport. It just is not right. So who is not doing their job? Who is not paying attention? Who is not listening? How is it that I have hundreds of videos every week of these people with nobody from the county showing up? And the city likes to blame the county, and the county likes to blame the city. You know, this back and forth thing, and everybody likes to blame the sheriff. The fact is, behavioral health is not showing up. Get people that are willing to help and actually get out there and do something. Thank you.
All right. Let me confirm with the clerk. We have no other speakers on that item.
Correct.
Then we'll call the roll on the consent calendar as amended. Clerk?
Vice Chairperson Lee?
Aye.
Chairperson Simitian?
Aye. Motion carries unanimously. Thank you very much. That takes us to item number 4, which is to approve the various appointments and reappointments and the privilege actions and the enterprise privileges that are identified in items 4A and B. Dr. Kranis, welcome. Anything to add or share with us today?
No, that's all. I appreciate the time and I'm happy to answer any questions.
All right, let me look to Supervisor Lee, and if he has questions, he'll ask them, and if not, he'll say, move approval.
Yes, moving approval of the appointments, reappointments, or just privileges of the medical staff as listed.
Thank you.
Thank you.
Happy to second. Let me check with the clerk to see if we have any speakers on this item.
We do not.
Call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you, Dr. Kranis, and thank you to your team.
Thank you.
That takes us to our next item, which would have been item number 5, but it was covered on consent. That takes us instead to item number 6, which is to receive a report from the public health officer relating to vaccines and COVID-19. Dr. Cody, you are up, ma'am.
Good afternoon, supervisors. This is Dr. Sarah Cody, and if I will try to share my screen, if it doesn't work, I will ask the clerk for assistance. I think. Can you see my screen, supervisors?
We can, and you're multi-talented, multifaceted, and successful. Thank you.
Fantastic. So good afternoon. I'll just give you a little update today. Now, unfortunately, there we go. So I'm going to, as always, just give you a brief update on where we are in the epidemic. Then I wanted to provide an update on masking as well as vaccinations. And for vaccinations, I have a special guest, Dr. Marty Fensterscheib, who will be joining me for that portion. So where we are in the epidemic, I think where we are is at a period where after a decline that slowed, that we're now actually flat and flattening, much the way we looked in October of last year. And so I will no longer predict what happens after this, but I'll just say that we are not declining anymore. As far as deaths, as you know from previous reports, the death reports are delayed. And so it's difficult to say because we have the data as preliminary for a month. But I think that we are now declining. I think that what you see there in that curve probably represents much of what we've seen from the late summer, fall surge. I wanted to briefly touch on the San Francisco Bay Area metrics that the health officers in the region agreed to give you a chance to ask questions if you have some. This was a bit of discussion over a significant amount of time among the Bay Area health officers. And what we came up with was that to feel comfortable lifting the requirement for indoor masking, we would need, our metrics would cover transmission, hospitalization, and vaccination. So those are the 3, transmission, hospitalization, vaccination. And then I'll explain a little bit about each one. So for transmission, it needs to be low and stable. And we wanted to have a metric that was standardized that anyone could look up and find. And so the CDC tracks community transmission across the country and color codes it. So if we are in the CDC's yellow or moderate category for 3 continuous weeks, we'll meet the metric. If we have a day where we bounce back up to substantial, then the clock starts again. So it needs to be 3 continuous weeks in yellow. That covers transmission. Hospitalizations must be low and stable. And for this metric, it is the judgment of the local health officer that hospitalizations are low and stable. As you know from all of our discussions, this depends on number of beds in the jurisdiction, on staffing, and on many other impacts to hospitals. And finally, vaccination. We could meet the metric if we meet one of the 2. So it's either 80% of the total population is fully vaccinated, or 8 weeks have passed since the vaccine has been authorized for 5 to 11-year-olds. So whichever metric we meet first, we could meet that. And in order to lift indoor masking, we need to meet all three categories: transmission, hospitalization, and vaccination. So here's where we are as far as vaccination. You can see that after this long tail where we continue to make slow progress toward first doses, we do continue. And then you can see in purple the boosters. As of now, we have changed our dashboard so that you can see both the percent of residents with completed vaccination, the whole population, which is 72.9, and you can see the metric that we've been tracking all along, which is ages 12 plus with completed vaccination, where we're now at almost 85%. And so now I'm going to turn it over to Dr. Fensterscheib for a brief update on both pediatric vaccines and boosters. There's been a lot of activity recently, and we will attempt to simplify it for you. Dr. Fensterscheib.
Thank you, Dr. Cody, and good afternoon. I'm back for a little bit of time for a short stay to help get the rollout going of the 5 and 11-year-old vaccines. So first of all, it is coming. The EUA for children 5 to 11 years old is going to be heard by the FDA panel on the 26th. And then following that, the CDC and which is the ACIP panel and the CDC director will then approve those recommendations. And that's likely to happen on November 3rd. So it's coming up very, very quickly, soon after Halloween. Remember that the pediatric formulation is the same vaccine, except it's a lower dose. And in the study of over 2,000 kids, they found that using 1/3 the dose, which is 10 micrograms, worked just fine. But it's still a 2-dose vaccine. So you get the first dose, and then 3 weeks later you get the second dose. So that will be necessary for all of those young children now. Now, in anticipation of the approval, the feds basically have purchased vaccines from Pfizer and are in the process of pre-positioning it in all of the states. The state of California announced to us that they have been allocated 1.2 million doses of vaccine in this first round. And that will vaccinate 1/3 of all of the kids in California that are 5 to 11. There are 3.6 million of those kids. The initial distribution and the ordering will take place this week, actually. We're putting in orders now so that the vaccine actually will get shipped the exact week, November 1st through 8th, when the authorization should come. So we won't have to wait around. That's the plan. The way the formula is working is similar, as you remember, to the way it was for the adult vaccines. The vaccines will be separated by those going to our multi-county entities, and we remember we have 2 of those, Kaiser and the Sutter system, which is PAMF, and then the rest to the local health jurisdiction. So it's an 80-20 split across the board. They expect to get this vaccine out within 1 week. And the ordering, as I said, has begun already, and we hope that it will all be shipped the week of November 1st through 8th. After that, the anticipation is that there won't be any shortage of supply. The federal government has purchased much more vaccine than is anticipated to be needed, and so there should not be a supply issue. After this coming week, where we're ordering it and redistributing, especially to some of the smaller providers, after that, there should be plenty of vaccine that would be ordered individually by all of the providers. One note is, because it affects the county system that has received its HRSA allocations directly from the federal government, HRSA will not be providing vaccine, at least just for this first week, so that we will be providing vaccine to the county system, but then it will be available following that 1 week. Also, the retail pharmacies will not have vaccine for 5 to 11 in the first week. So that's the update on that. And then on the boosters, more information is coming in every hour, I think. There was just an update that I'll give it to you in a second. But remember, boosters for Pfizer have been approved already. And again, those are for 18-year-old and older who have had a vaccine at least 6 months prior. They had finished their series of Pfizer and that they fit into a high-risk group, meaning that they're either over 65 or work in a high-risk situation or have an underlying medical condition. Moderna booster vaccine was just approved at least by the panel of the FDA on the 15th, and the FDA advisory committee made that recommendation to the FDA. And I just see this came over the wires now that the FDA has taken those recommendations, and so the Moderna vaccine has been authorized by the FDA, and it will now go on to a meeting tomorrow by the CDC for its final approval. The J&J vaccine also was added to that, and so the J&J vaccine will also be recommended as a booster for those that have the vaccine already. And then one other thing that they did also authorize, that the panel actually, I should say the FDA itself authorized, but the panel didn't get time to do, is the mixing and matching. So if you had one dose of, if you finished the series of Pfizer, for instance, you could get a Moderna booster, and vice versa if you received Moderna. And the same for J&J, you then will be eligible at least to get any of the vaccines as a booster to J&J. So that's what we call mix and match. And all of this will go before the ACIP tomorrow and the CDC director. So hopefully by the end of this week, we may have all of the booster situations taken care of. And I will turn this back over to Dr. Cody.
So that concludes our presentation, and we're happy to answer questions.
Thank you, Dr. Cody. Thank you, Dr. Fensterscheib. Nice to hear from you both. Let me go first to my colleague, Supervisor Otto Lee, see if he has comments or questions. I know I have a few, but I'll defer to you for the moment, Supervisor Lee.
Thank you. First of all, welcome, Marty. Good to see you again. Very glad that you're back to help out on the distribution of the 5 and 11-year-old, which of course will be coming soon and hopefully, as you said, around early November. And you mentioned that the initial week, we will have to rely on the existing inventory of the vaccines that we have and not the new allocation from HRSA, right? So I have heard these things on the grapevine, I'm not sure how true it is. And the question was, they said that they have to use certain type of a purple bottle vaccine for kids versus the adult ones and not able to use adult ones. Is there any truth to it, or this is just another fake news I just heard?
Yeah. So thank you for that question. I'm sorry I did not clarify that on our slides, but the pediatric formulation is not the adult formulation. So even though we're sitting with a good amount of the adult formulation of Pfizer, we cannot use any of that for the kids. And the reason being for safety reasons mainly, because it's 1/3 the dose, and if we're worried again, trying to measure that out and making a medication error or giving a child an adult dose for whatever reason. So the CDC and the manufacturer will be coming out, as you said, in a small vial that is orange colored, and it will have the right, it will have the right amount. And so we won't make any mistake, but we can't use, again, any of the Pfizer that we currently have. And that's why they're pre-positioning all of this newly formulated vaccine that we should have in hand the week that it's approved or authorized, rather. Thank you.
So does that mean that after the approval, the first week before we receive these orange bottles, we're not allowed to use the ones we have for the kids for the first week?
That is correct. That is correct. So forget about using any of the currently available Pfizer vaccine, which actually comes in the purple vials, right, for any of the kids. So so basically we have no vaccine currently that can be used on any children between 5 and 11. 12 years and older, that adolescent group, we can use the adult dose, and we have been using that.
Right. And you mentioned the volume. I guess so the current dosage is about what, 30 milliliters, and the new one will be 10? For the
30 micrograms, 30 micrograms. And so then the child dose will be 10 micrograms or 1/3. It's the same vaccine, but we
Right.
have to be very careful to give the right dosage.
Correct. Now, the Moderna vaccine's dosage is, I was told, is a lot higher in terms of the amount it was given. It's just a completely different volume, right?
Well, it's interesting that you asked that. So the 30 micrograms that's in the Pfizer adult dose is different in the Moderna. It's actually 100 micrograms. So
Right.
it's actually there's more of that in the Moderna. However, it's a good point that the booster dose of Moderna. So if you got 2 doses of Moderna, or you choose to get a Moderna booster dose, you will get a half dose. So we will use the Moderna that we have. We will use the same vials and formulation that we have, except we will draw up 1/2 the dose as the booster, which is 50 micrograms. I know it's a lot of numbers, but that's kind of the bottom line.
Yes, if this is not confusing enough, but in any case, but thank you. But so for the Pfizer booster, there's no difference, right? That will still be the 30, correct?
That's correct.
Okay, very good. Someone has asked me whether you could get the flu shot and the COVID vaccination shot on the same day, and if they can, should they do in different arms?
Yeah, absolutely. If the provider has all of that, you should do it. Do it in different arms, but you can get them at the same time, and this way you get them done, and you're all done in one shot, rather 2 shots at one time.
One time, right? And for now, there's still no word on the mixing and matching from the FDA, the CDC yet, but that's to be determined down the road, right?
The panel didn't get around to discussing it, but the FDA on their own, again, which is the actual body that makes the recommendation, decided to go out and say, yes, we do recommend the mix and matching. That just came out on the wires as we speak. And then that recommendation goes to the CDC tomorrow. And so hopefully they will approve that. And so we will be able to use mix and matching by the end of the week.
Wow, great. That's really exciting. Okay, so the other issue that people talked a lot about is regarding the lifting the indoor masking requirements and the metrics here. And certainly this is really important, as you heard one of our speakers today talked about the need for not masking with this requirement. So look at where we are, since we're already 85%, right, of folks who's been vaccinated. So we definitely have met the 3rd requirement for the vaccination. So the question really is the first 2, which is whether we are in the low and stable for transmission for continuously more than 3 weeks, and that our hospitalization is also low and stable. How close are we getting the first 2 conditions being met at this point?
So we actually have not met the vaccination metric because it's the percent of total population.
I
so, yeah, so our residents 12 and up is 84.8%, but the residents of the whole population is 72.9.
I see.
So, but once 5 to 11-year-olds can get vaccinated, if we can increase that, we'll be able to get to the 80% total population a little more quickly.
Right.
So we've not met the vaccination metric. We've not met the community transmission metric because we are still in orange. We're sort of hovering at low orange. I would say we're yellow-orange, but we're not yellow. And the hospitalization, I was feeling pretty comfortable. Interestingly, and I can't quite tell you why, the COVID hospitalizations have actually taken a little uptick. So we're keeping a very close eye on that.
Got it. Yeah, no, I mean, these numbers obviously changes every day, and thank you so much for monitoring so closely on these numbers. And it's something that we've been monitoring, or you've been monitoring for the last year and a half so closely on a day-to-day basis. I just want to say thank you, Dr. Cody and Dr. Feinstein, for coming back to help us on this efforts for our 5 to 11-year-olds. I really, really appreciate the hard work that you guys are putting in. And that's all the question I have. Thank you, Chair. Chairperson Minnie-Moon.
Chairperson, I'm sorry, you're on mute.
Thank you. Dr. Cody, Dr. Fensterscheib, let me begin by asking, following up on the masking requirements. I think I understand the metrics, and thank you for the further clarification. That being said, we've got 2 or 3 counties in our area that have been reported to have either lifted or modified their masking requirements in some way. Are they really at all 3 of these criteria levels, or are they perhaps being a little more flexible or less rigorous, depending on how you want to put it?
So first, let me say that I, of course, can't speak for the other counties that have modified the criteria in some ways. There are not any Bay Area counties that have met the regional metrics that we settled on. So no counties in the Bay Area that have masking mandates have met that metric. Some counties in the Bay Area, San Francisco and Marin, there is perhaps another, have carved out narrow exceptions. So yes, by and large, everyone needs to meet these metrics to lift the vaccination mandate, but then they've carved out a little exception here and a little exception there. In Santa Clara County, we've always endeavored to keep our guidance as simple as possible. And so we are doing that in this case as well.
Got it. Then, Dr. Cody, I know you're always anywhere from reticent to disinclined to make predictions, and I understand why, given the roller coaster ride we've all been on together. But as I look at these criteria, the transmission, hospitalization, and vaccination criteria, it strikes me that the earliest we might be looking at to lift the indoor masking requirements is late November. Is there anything about what I've just said that you think is inaccurate? I'll ask the question that way so you don't have to make the prediction. I'll make the prediction.
My prediction is it wouldn't be that early. I think that the vaccination metric is going to take some time to reach. So if we reached it by the 8 weeks from full authorization of Pfizer for 5 to 11-year-olds, of course, that clock won't start yet. We hope it'll start soon. And I don't know whether we'll reach 80% first or we need to wait out that 8 weeks. So that's going to, probably hold us through December. And then the question is, will we have a winter surge? I think we'll probably will have some kind of a surge. I don't know how much, but that may complicate reaching the transmission metric in particular.
Got it. Then, as I look at the sheet that I have in my hand, which happens to be the sheet from the PowerPoint that you have up on the screen, I'm looking at the purple, which is the number of residents with a booster dose. Do you or Dr. Fensterscheib have any sort of reaction to those numbers? More better than you expected, a little slower than you expected, about what we'd expect given the fact that it was only one vaccine with a emphasis on 65 and up? What's your take? Are we? Go ahead. I'm sorry.
Yeah, I think that in our county and really across the state, we anticipate much more of a surge in demand for boosters than we've seen. And we really want to get the word out to the community that particularly for people that are 65 and up, get your booster. It can, really give you good insurance to keeping ensuring that you, don't land in the hospital. So there is the vaccines are phenomenal and amazing and excellent, but they are not 100%. there is some waning in immunity, and particularly if you're 65 and up, go get your booster. And I think that message is going to become a lot simpler to convey once anyone's available, regardless of your original vaccine series, you can go get a booster. I think it has been challenging. Well, if you got Pfizer, you can get a booster, and if you did it, then you have to wait, and right, it's a little bit more complex. So 65 and up, get your booster. And if you've got an underlying medical condition, some chronic disease, go get your booster. That's really the top line message.
All right. And on the status of go get your booster timing, if we have what I'll call clarity and sort of full authorization to move forward with boosters and by full, I don't mean level of approval, I mean clear authorization to move forward with boosters by the end of this week. How soon will we be able to offer all three vaccines, Pfizer, Moderna, and J&J, at our various sites in the county?
Actually, they're gearing up right now, so we're anticipating when the authorization will occur, hopefully the end of the week, and then we're ready to go right away. So if people want to plan it as soon as the authorization comes, they can make an appointment or drop in at any of our sites and get a vaccine as a booster for any of the vaccines any series that they've already had.
And I just want to make sure I don't read too much into that, Dr. Fenstribe. So if the authorization comes through by midnight on Friday, does that mean somebody could drop into one of our clinics on Monday and get the booster of their choice?
That's our understanding at this point, yes. As long as those authorizations come through and we don't have any glitches in there, but we're assuming they will, and then we are ready to go immediately.
Okay. I don't think I have any other questions. Let me circle back to Supervisor Lee, see if he's had any other comments or questions he wants to share at this time.
No further questions at this point. Thank you.
All right, then let me go to the clerk and we'll see if we have folks who are queued up to speak on this item. Madam Clerk?
Currently have one request.
Let's go ahead and hear from that person who will have up to 2 minutes.
Thank you. Our first speaker is Tino. I've unmuted you. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, in regards to the three different metrics, transmission, vaccination, and hospitalizations, in the August 25th Health and Hospital Committee meeting, Dr. Cody revealed quite a bit of concerns. First of all, our county was not in line with the state guidelines as to how to fill out death certificates, inflating the numbers by 22%, which amounted to around 300 over-reported deaths. That is a huge concern, and I'm appalled that the county is not actually holding her accountable and believing her every word moving forward. Secondly, transmission rates, the testing. She specifically said that the PCR test doesn't tell you if you're infectious. She also said that it can mean that it's quite sensitive. We are not using multiplex tests across the board. We are not even differentiating with the different positive test results for the different types of testing. Those types of tests immediately affect the hospitalizations as well. I do have questions about hospitalizations. Are we sequence-based testing everybody who goes in there? Are we properly diagnosing them? I've mentioned before that Dr. Anthony Fauci previously said that we would have to overhaul our entire testing strategy in order to properly diagnose and treat people. The vaccination rates, regards to the kids, we have not been discussing their recovery rate or their extremely low risk when it comes to COVID-19. What have we found out about the initial rollout with our youngest adults and teenagers and the effects with myocarditis 6 to 8 months out from clinical trials? What are we going to find out about our most vulnerable children with these shots? What are you guys doing? Why are you rushing this? Josemidian, you gotta search your soul. I'm telling you, pause, reassess.
That concludes our requests.
Thank you, Madam Clerk. Just to be clear, there are no other speakers on this item?
Correct.
All right.
Sorry, one hand just went up.
All right, we'll take that one more speaker. Folks, it really will be helpful if you would please raise your hands early so we know how many folks we are going to be able to accommodate. Let's take that one more speaker, give them up to 2 minutes, but that will be the final speaker on this item.
Our next speaker is Irvish. I've unmuted you. You'll have 2 minutes to speak. Please go ahead.
I wanted to thank Board of Supervisors, especially Supervisor Submission and as well as the Supervisor Orderly. I'll reserve my comment for the next topic though. Thank you very much again.
Thank you. So somebody who was early, not tardy. All right, thank you. That takes us to item number, well, excuse me, we do have a report to receive. If I can get a motion from Supervisor Lee to simply receive the report.
Yes, first of all, I want to thank staff. We had a very successful day in the Bay, and for staff, public health, to make the mobile vax happen. They were extremely helpful, and we've got the people really getting their both the flu vaccine and the booster and COVID vaccine on day in the Bay this past Saturday. I just want to say personal huge thank you for staff making a really successful event. And that being said, go ahead and move to receive the report. Thank you.
All right, motion by Lee, second by Simidian. Madam Clerk, please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye, motion carries unanimously. Thank you. That takes us to item number 7. And item number 7 is our monthly report on the sexual assault forensic exam program. Mr. Lorenz, I see the report has your name on it. Any initial report from you or your staff?
Thank you, Chair Simidian and Supervisor Lee. So you do, in fact, as you mentioned, have the written report. We do also have Kim Walker and Andrew Berlini to answer any specific questions that you may have.
Thank you very much. Supervisor Lee, I've got a couple of questions, then I'll turn to you, and then we'll go to members of the public, if any, who would like to speak. If you are a member of the public and would like to speak on this item, I would ask you to go ahead and raise your hands now so we can get a head count, make sure there's time for all who would like to participate. Let me begin by addressing my questions to, I guess, Ms. Walker and Ms. Berlini. As I read these materials, forgive me, the energy saving lights have decided to turn themselves off. There we go. As I read these materials, the new interim site space will be ready and in service 4 days from now on October the 24th. Do I have that right?
Yes.
And thank you, Ms. Walker. And Ms. Walker, we've spent a fair amount of time discussing the importance and distinction between a dedicated site as opposed to a designated site. I gather that this interim space, even with the interim designation, will be a quote dedicated site, meaning it will be specifically limited to and used for the SAFE program. Do I have that right?
Yes.
Thank you. And one of the areas that we had discussed previously was whether or not the triage process could be made somewhat more confidential. And I guess I would ask you if you feel like you've been able to make progress there. And by the way, I see Allison Kerr from the Stanford hospital system there as well. So thank you for joining us, and we'll consider you a resource as well. Go right ahead, Ms. Walker.
Yes, we have been working very closely with Stanford on that to make sure that the process from the time a patient arrives to the time that we see them is limited to as few people as possible, with the need to know the story and the need to understand why they're there. So they don't have to repeat their story or the details to more than just really 1 or 2 people.
And do you feel like you're making satisfactory progress in that regard?
Yes.
Thank you. There was also some discussion about minimizing the need for questioning and repeated sharing of information by way of education on the campus and with folks who are part of the resident system there. Have you been able to make progress in that regard?
Yes, we started doing trainings with the resident directors, and we have upcoming trainings with both their bosses, which are the program managers, and with Vaden health center will be working with them as well.
And this may seem like a question about the obvious, but given the fact that, in any community, people come and go, but certainly in a residential campus setting, we're going to have students who come and go and people who change in those positions. Does that mean that you anticipate that sort of outreach and education effort being a continuing exercise?
Of course, we want to iterate that training so that we not only can make sure we capture everybody as they roll through their positions, or as students are oncoming to the campus, different semesters, and then making sure that sometimes you just need to hear it more than once before it kind of is something that's accessible information for you.
Okay, and the interim site, which is dedicated, will become a permanent site once physical modifications can be made, which means we have to wait on the folks at Oshpod at the state level. Am I remembering this correctly?
Yes.
And it seems to me, if I remember from prior meetings, and I've got a couple of notes here as well, the key issue there is the ability to put a shower in the dedicated space that would also be a dedicated shower space. Am I remembering that correctly?
Yes.
Okay, so that's in the works, but we have to wait on Oshpod. Yes?
Yes.
Okay. Thank you. It sounds to me like things are in a much better place, and I know you'll stay on it. We have an audit from the folks at our Harvey Rose organization that provides our management audit function here at the county. So we'll be seeing that sometime in late November, early December. And what would you like to share about the situation at St. Louis? Because that's obviously part of our larger look and see as we've gone through this conversation over the last few months.
Well, one of the most important things we want to make sure is that the workflows are smooth at St. Louis, which it looks like we have everything in place, or working on getting everything in place for that to happen. And then addressing patient experience, which we're doing at all locations, especially given all the work we've done at Stanford, to make sure all response locations meet those same requirements.
So I don't want to be unduly optimistic, but it sounds to me as if the experience we've been through at Stanford, reviewing the initial operation of the Stanford facility, has been and will continue to prove helpful in informing some of the judgments you have to make at St. Louis. Am I connecting the dots correctly or no?
Yes, absolutely. Anytime that patients are coming forward and they have opinions that they want to share, we want to make sure that those voices are heard and considered at all subsequent locations and all the work that we do.
Good. Pleased to hear it. Ms. Berlini, Ms. Kerr, anything else? I feel like I've got my questions answered, but I want to go to Supervisor Lee before we go to members of the public. Ms. Berlini, I don't see you lighting up, but I do. Nope. Ms. Kerr? Nope. All right. Then I will say thank you to you all, and thank you, Ms. Lorenz, to everybody on the team for making so much progress. And I'm really very pleased to hear that it will help inform the work done in each and every one of our other locations as well. Supervisor Lee, your questions and comments before we go to the public?
Thank you. Yeah, so I did get a tour about a month or so ago over at the Stanford Safe location and get to see a new space that was going to be renovated and to be dedicated. So it's very exciting to see the progress there. Just a quick follow-up question is, do we have any new time frame and timeline that we think the renovation will be completed? Or are we still guesstimating at this point?
Ms. Walker? Oh, go ahead,
I
Ms.
think it's
Kerr.
an Allison Kerr question.
Sure. Thank you very much, Vice Chair Lee. So we are in the midst of finishing the planning, working with Kim and Andrea to make sure the space plans are finalized. It gets submitted to Oshpod, as you know, and then we really are contingent on their turnaround time. We have outlined a year for where that might occur, but we're hoping that they will be faster than that, given that we've already engaged with them, and we're hoping that they will be able to turn that around faster. and we'll continue to work with Kim and Andrea and the program as we work towards that transition. So we're hoping for a much shorter timeline, but we are obviously contingent upon OSHPD returning the plans to us approved.
Okay, great. Thank you very much. And that's all the questions I have for today.
Thank you. And Ms. Kerr, I'm going to press you just a little bit. I think this is hopefully an easy one. Can we count on your organization to be ready to move the moment you do get the OSHPD approval?
Absolutely. So we are funded. We've had, I think, Kim, 5 or 6 planning meetings for doing the designers. We already have an architect. As soon as they give us the approval, we're ready to go.
All right. Thanks very much. Let me turn to the clerk and ask if we have speakers on this item.
I have one request.
Let's take that speaker.
Our first speaker is Irvish. I've unmuted you. You'll have 2 minutes to speak. Please go ahead.
Thank you very much to Board of Supervisors. I want to specifically, and as well as to the Supervisor submission and the Supervisor orally, and as well as the city staff for the Santa Clara County Health Medical Department. I wanted to mention about that, how the program is being held. Though it has been noted that there has been 60% increase compared to the cases that's been increasing as a part of forensic exam that has been set up within the different medical facilities at the Stanford as well as Santa Clara County Health Valley Center, and as well as a part of a public health department in the Santa Clara County. However, it is very important to note here that along with the exam, it would be important that that there are special forensic, along with the special forensic exam, the counseling be provided as well as part of a report for the last 3 years. Comparatively, the number of cases has been increased, and though it has been noted as well that the staff, the capacity and the services of the staff, as well as with the nurses, the medical aid, and as well as the differential services in terms of providing the help to the child abuse survivor has been increased as well. It is to note here that as these cases are increasing, it is important to note about the people getting affected and people getting the counseling as a part of a Santa Clara County's afford towards the program, and also to note that in such cases that this certificate be provided as a part of a digital certificate services to the people, such that the records be maintained within the justice system as well as within the public health department of County of Santa Clara. Thank you very much.
And that concludes our requests.
Thank you very much, Madam Clerk, and thank you to all. I think we continue to see progress made. Thank you to all who are making that possible, and we'll stay with this. We have reports scheduled for November and December, and my hope is that at that point we will be able to say that we have wrapped up the work of the committee in ensuring that we're engaging in best practices at all the facilities, and we will no longer be in monthly meeting mode on this. We will want to make sure that we have some kind of regularly scheduled follow-up / check-in, and we can talk about what that looks like when we get to December, just to make sure that we stay on top of the situation going forward. So Supervisor Lee, if you'd like to offer a motion to receive the report on item number 7, that would be gratefully entertained.
So moved.
Second by Simidian. Madam Clerk, please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you all once again. We'll see you next month. And I should just say, and I can't remember if I said this at the last meeting, so forgive me if I'm repeating myself, I too found the tour very helpful. There are times, quite candidly, when you go walk a site and you think, well, yeah, that's what it said on the plans, and that's what I saw, and it's not, frankly, all that helpful. In this instance, I really did think that, as Supervisor Lee mentioned, it was helpful to walk those steps, see the facility, and get a sense that was a little more real and a little more immediate in terms of what someone would have to go through under those very difficult circumstances. So thank you for accommodating the visits. I know that was an extra effort. Much appreciated. All right, thanks again. We'll see you next month. That takes us to item number 8, which is to receive the report from the County of Santa Clara Health System relating to options for expansion of health coverage for residents of Santa Clara County. And we will turn to our staff. The report, of course, comes to us from Mr. Santiago and Ms. Rosas. So, Mr. Santiago, do you want to start us off?
Yes, and good afternoon, Mr. Chairman Samidian and Supervisor Onali. It's really a pleasure to be here with you. There's a couple things. As you recall, last month we gave you a history and background of the Primary Care Access Program, and almost simultaneously there was a board referral, if you remember, that to look into various options for us of expanding that program based on the experience, as well as there was some testimony from the public in Spanish requesting some very specific things. So what we have for you today is a presentation from Ms. Rosas, CEO for Valley Health Plan, in responding to present to you a variety of options and models that builds on the experience as well as lessons learned. And if you recall, this is something that we started off with general fund and Measure A funds early on, a few years back, in partnership with the community health clinics and others. So Ms. Rosas will give you an update related to what we're offering here in terms of options.
Great, thank you so much, Renee. Can you all see my screen? Hopefully this works.
We can see you, but we can't see anything that you are attempting to post on your screen. Is that correct, Supervisor Lee? Okay.
I get it. Okay, so I think I've figured this out.
There we go.
Yes?
Yes.
Good to go.
Okay, great. Thank you. It's just that it's it's really far away from where I am. So let me give you some of the goals that we had when we started working on this, which we actually started working on this over the summer. So we got a little bit of a head start. First of all, we think it's really important as we rethink PCAP and talk about expansion, not only for the number of participants, but also for services and what the needs are for the community. We think outreach is really important, both for the current enrollees so they understand that they are part of this program, as well as to both the community health clinic staff and VMC staff on what other options there are besides PCAP, because some of these folks may be eligible for Covered California. Some may be able to fall into the individual family plan if they can afford the cost. Some may be eligible for Medi-Cal. So we want to make sure that those options are fully vetted. And then we want to make sure that we fold the PCAP into our current outreach processes. We also want to, what we have done today is given you a number of options from 200%, where we are currently, to 400%. And we also will include a quality program, which you'll hear about both in our annual report as well as today in this section, about really building a quality program that supports access and quality of care. And we also have heard, listening to our stakeholders, that there's a real need to reimburse on recertification. Every year there is a recertification. I think that's been suspended because of COVID, but generally there's a reimbursement. There's a recertification process. So reimbursing the clinics for that work, we think, is an important goal as well. We want to align PCAP with the U.S. Preventative Services Task Force, which is USPSTF. It's always a mouthful, but these are the recommendations on preventative care, and we really want to fold that into PCAP, and we'll get into that in a moment. We have a slide on that. And also we want to expand access to mental health, behavioral health, dental, and vision. We'll take probably all of 2022 to fold those in and make sure that that access is there. We think that's a really important goal. And then finally, our clinic contracts will standardize the codes for reimbursement, co-payments, and encourage regular data submission. And we'll talk about that as well. Phase one, we want to consolidate operations at VHP, because right now those are shared across VMC or HHS and VHP. I think it will be easier to administer the program if it's just over at VHP. We need to contract with the CHCs That's important, and have that PCAP in our contracts. We need to implement the quality program as we discussed and work on expansion of behavioral health and vision and dental. 2023 will explore other payment methods. Right now it's on a capitation and we'll talk about that. But there may be other ways of reimbursing them for this care. So we will explore that in 2023. And we will proactively educate and support enrollment of county residents in the program within the regulatory parameters. We are a Knox-Keene licensed health plan, so there are some parameters on that. But we do think outreach and engagement is important. And we also think that the opportunity, now that both BHP will be going on to Epic, as well as a number of the clinics, really will allow us to leverage that data in a way that will improve care and improve coordination. So we're excited about that, and I think that's a great 2023 goal as well. A little bit about USPSTF. It's an independent group. Often you'll hear about them in the news. They'll recommend taking aspirin as a stroke preventative or not, as they recently determined that it was not something that everyone should do. That's the USPTF. These are the these are the services that they have on their board. So it's all preventative, it's all primary care services. And since the Affordable Care Act, these services have been required by plans have to give these preventative services with no cost sharing, so no co-payments or deductibles. Important to note that the task force does not consider sort of the treatment of someone who is ill. These are preventative service guidelines or recommendations for preventative care. So someone who's ill with symptoms or that, they do not weigh in on that. This is purely preventative. And just a little bit of history, ARC has supported USPSTF since 1998, and they provide all that administrative support. Just wanted to give you a quick look of what this looks like. You can go to their website, lots of great information. You'll see here, I've highlighted pre-diabetes and type 2 screening. And then so if you click that, you'll get the population, and it refers to ages 35 to 70. It'll give you the recommendation. They have letter grades from A to I. A and B are recommended. C depends on the patient, specific circumstances. And then D is not recommended. I is inconclusive, basically. There's not enough data to support a recommendation. As you may be aware, I think we've heard for the last few years is that healthcare is moving away for fee-for-service. It's a hard road and moving into a value-based payment initiative. This is true for all of healthcare. It's part of the ACA. It's part of many initiatives, both in California and across the country, to really get away from paying for services and instead begin to pay for outcomes, pay for people to be healthy. So we're doing that as well. We're really revamping our value-based payment initiative and our pay for performance. So we are currently focusing on having 80% of our population in a value-based payment. Covered California is requiring this. It's likely to become a requirement across the board. There's a lot of focus, both from NCQA and Covered California and CalAIM on health equity. And that is part of our accreditation for NCQA that we're pursuing. It's very rigorous, but this is really, everyone's beginning to look at how do we address the equity issues in healthcare through the value-based payment process. And so we're doing a lot around data capture. We want to work with our clinics very closely on providing coaching and operational improvements. We want to really incentivize sharing of data as well, so that we get timely encounter data, for example. And PCAP will all be part of that. We will just consider that another line of business that is part of the value-based payment, part of all of those initiatives as well. So currently we have about 8,100 participants in PCAP. It is at a 200% of federal poverty limit, and there's no quality program. The $1 sort of in there, but there's no like real robust quality program. To continue this, we would need about $4 million. If we wanted to increase it at that level, at 200% of FPL and 20,000 enrollees, we're looking at around just under $10 million. That's an increased enrollment, soft marketing programs, and trended growth. So we're looking about, that's where we would be at 20,000 at 200% of FPL. If we went up to 300% of FPL, and let's assume that we had 25,000 enrollees, and we'll talk about that in a moment about the enrollment, because we know that there's some changes in Medi-Cal for those over 50, and we'll have a brief discussion at the end of this, because there's some considerations there as to how that could affect the numbers. So enrollment of 25,000 up to 300% of FPL, so an increase on the FPL with a quality incentive program with 50% of the quality dollars being paid out. We're looking at about 12.4 million or so. And then if we went to 400% and had 30,000 enrollees, which would be an enormous increase, right? If we're at 8,100. That would be a lot of, and I think it would take us some time to get there. We're looking at about 15 million on an annual basis. That's with a quality program, capitation of $12 per member per month or $12 per enrollee per month, and incentives and expanded growth. So one of the questions, of course, is that there will be a change in Medi-Cal eligibility with the new law that was passed. So around June of 2022, we will have those over 50 potentially in Medi-Cal. That may decrease the number of folks who could be in PCAP. It's a little hard to tell. Although the Trump administration is over, there's still a lot of fear around public benefit. There's a lot of reticence about signing up. I think that's true even for PCAP, so we'll need to do some outreach. I think if we saw an increase in Medi-Cal, it would be slower than anticipated or even hoped for. So I think that's an issue. So we tried to, come up with the numbers based on what we think we could potentially see, but I think it would be a slower growth to get to 30,000. I don't think it would, even with really a lot of outreach, would we see that. And that's where I'll just go back to the previous slide and see if you have, are there any questions, or would you like me to go back in the deck on anything? Or Renee, please feel free to jump in.
Let me ask that you hold off unless Mr. Santiago, you have additional comments. I'd like to check in with the clerk and see how many speakers we have for this item.
We have 6 requests.
Okay. I'm going to ask that members of the public who would like to speak, please raise their hands now so we can get an accurate count on the number of speakers and allocate time accordingly. And do we have Spanish language translation? I know last meeting that was an issue, Madam Clerk.
I do have a Spanish interpreter in the room, and I'd like to ask Rosario to announce in Spanish that now is the time to raise your hand for public comment.
You anticipated my request. Go to it, please.
Rosario, whenever you're ready.
Sure, thank you. Sí, en este momento los miembros del público, si quieren hacer un comentario, es el momento de empezar a subir la mano, por favor. Gracias.
All right, thank you very much. Let me turn again to the clerk and say, how many speakers do we have on this item?
We are steady at 6.
All right, then let's call it 6 speakers, and we will provide up
Apologies,
to 1 minute.
Great, we're up to 8 now.
We're going to cut it off there, and we're going to go with 1 minute apiece, please.
Okay, thanks very much. Our first speaker is Respinoza. I've unmuted you. Please accept the unmute, and you'll have 1 minute to speak. Please go ahead.
Good afternoon. This is Raimundo Espinosa, CEO of Gardner Health Services. Thank you for allowing me to speak. Supervisors, I want to thank the VMC staff for coming out and talking to us about the potential expansion of the PCAP program. And we had a fruitful discussion, I believe, in terms of the way that it's going to be organized. Our outstanding issues were the reimbursement, and they said that they would take a look at that. And the other outstanding issue, I think, for us is the outreach that's really critical because of the reluctancy of people to participate. And so I think if we could get some support in those 2 areas, I think we're good with it. And again, I really appreciate the staff coming out and talking to us and trying to get our input in terms of how to structure the program.
Our next speaker is Case Hill. I've unmuted you. You'll have 1 minute to speak. Please go ahead.
Hi, thank you, Health and Hospital Committee members. My name is Casey Hill, and I'm the Executive Director of Vegilution and part of the Si Se Puede Collective. Over the past 2 years, I've met so many farmers, restaurant workers, mobile vendors, and other essential workers who, even if lucky enough to retain their jobs, feel enormous pressure to continue working, even as they worry about exposure or feel ill or symptomatic due to the lack of healthcare coverage. Through the collective's Jobs to Grow program, we have had the opportunity to learn firsthand from East San Jose food entrepreneurs about the hardship that the lack of health insurance creates for working families. Despite their central role in our food economy, keeping us and our families healthy and well-fed, many workers throughout our food supply chain are ironically the most vulnerable to illness themselves. I ask that the county adopt model number 3, which will expand eligibility and access to healthcare coverage for thousands of individuals like those you'll hear from today. This will ensure that our county's food system, childcare system, its workers, and their families are protected. Thank you.
Our next speaker is Gabriel. I've unmuted you. You'll have 1 minute to speak. The timer will start when you begin speaking.
Hi, thank you. This is Gabriel Hernandez, Director with the Si Se Puede Collective. I again want to echo Gardner's health clinic's suggestions around reimbursement and support for their outreach. We too, as a place-based organization and a group of organizations that have the trust of the community, can work with the county to ensure that we again begin to incorporate and get people the healthcare coverage that they deserve. We also support the model number 3, raising it to the 400%. And we also ask that you move this item as quickly as possible through the system to get it back to the full board for consideration. Thank you all, especially you, Supervisor Simidian, Supervisor Lee, for the leadership in this, and hoping that we're successful in having this happen. Thank you.
Our next speaker is Rosie Lopez. I've unmuted you. Please go ahead.
Thank you, Health and Hospital Committee members. My name is Rosie Lopez, and I'm the Early Care and Education Manager from Girl Family Services, and we are part of the Si Se Puede Collective. Our advocacy and outreach work focuses on housing, immigration, childcare, leadership development, education, economic opportunities, environmental and food inequity, and COVID-19 recovery efforts. Following the devastating impact that COVID-19 had on our East San Jose community, we were motivated to find creative ways to support, engage, and save lives in our community. However, accomplishing these projects safely can be challenging, especially as frontline workers. We face high COVID-19 exposure, risk from direct contact with community members, while many of us do not have health coverage. This year, the Si Se Puede Collective has started our Jobs to Grow Mobility Labs program to teach families how to start businesses in the fields of food and service. To better help these families, we need your support by expanding access to healthcare coverage to families like ours. This will ensure that our families are healthy and that families worry less by providing them with healthcare coverage.
Our next speaker is Irvish. I've unmuted you. You'll have 1 minute to speak. Please go ahead.
Thank you very much again. I wanted to thank Supervisor Submission as well as the Supervisor Orderly for the opportunity to speak again. I want to specifically mention about the recent 2020-2021 legislation bill that has been introduced to improve the healthcare reforms, specifically with regards to the agenda item number 8 for the health coverage for the residents of Santa Clara County. In order to improve the healthcare reforms, there has been recently Senate Bill 326 that's been signed for the healthcare coverage to be provided as a part of federal healthcare reforms to all the citizens of the United States of America by the California Governor Gavin Newsom, and as well as the Senate Bill Assembly Bill 653 that has been provided to provide the medication assisted treatment grant program to issue the grants for the citizens. So request to implement both.
Our next speaker is Maria Borayo. I've unmuted you. You'll have 1 minute to speak. Please go ahead. Maria, you'll have to accept the unmute.
Hi, this is Maria Borrayo. I am one of the members of Juntos para Crecer, Jobs to Grow from Colectivo Si Se Puede, and they are giving me the opportunity to learn how to open my own business, preparing food or selling food. Being on this program is really helpful for me, but what concerns me is to be without medical insurance. And I see a lot of families in that program who doesn't have insurance. And this is really, really concerned because our community needs to be healthy. And I would like to ask you please to approve the county model number 3. And being successful in this program is to be healthy. And thank you so much for the opportunity.
Our next speaker is Brenda Arenas. You'll have 1 minute to speak. Please go ahead. Brenda, you'll have to turn your microphone on. Rosario, could you try in Spanish? She'll have to accept the unmute. There we go.
Gracias. Mi nombre es Brenda Arenas, navegadora comunitaria de Greer Family Services. Somos parte del colectivo Sí Se Puede. Nuestra labor de defensa se centra en la vivienda y las necesidades básicas, la inmigración y el cuidado de niños. Tras el impacto que tuvo en nuestra comunidad el COVID, nos motivó a encontrar formas creativas de apoyar, a comprometer y salvar vidas en nuestra comunidad. Sin embargo, llevar a cabo estos proyectos de forma segura puede ser un reto, especialmente como trabajadores esenciales nos enfrentamos a un alto riesgo de que no tenemos seguro médico. Pues esperamos que todos nos apoyen y digamos sí al nivel 400. Gracias.
So, can you hear me? Yes. Okay. My name is Brenda Arenas, and I'm part of the girl community and part of the Sí Se Puede collective. And our main job has been focusing in housing and also basic immigration needs as well as children needs. But we have had an impact due to COVID, and we are having different and creative ways of how to deal with our community issues, but we have always been challenged as essential workers. So we are always in a very high risk because we are not having a medical insurance. So please, I would say yes, approve this. Thank you.
Our next speaker is Graciela. I've unmuted you. Please accept the unmute and you'll have 1 minute to speak.
Hola, buenas tardes. Mi nombre es Graciela Santillanes. He vivido durante 17 años en San José, California, pero este último año es muy difícil a mí y a mi familia, ya que perdí mi trabajo. Mis ingresos eran muy pocos para cubrir mis necesidades básicas. Mientras que veía fallecer a mis amigos y a seres queridos a causa de la pandemia. Me sentí impotente. Me enteré del colectivo Si Se Puede. Me inscribí para una nueva oportunidad para saber cómo le pido a la comisión que garantice que nuestras familias se mantengan saludables y enseñar a nuestros hijos cuando se sientan mal puedan acudir al médico. Mi familia y mi comunidad merece tener acceso a al cuidado médico.
Rosario, do you need to ask for any clarification? Did you get that?
No, I have it. Thank you. My name is Graciela Santillanes, and I've been living here in San Jose for the last 17 years, but the last year has been very challenging for me because I lost my job. Anyways, I was not having a very good income, but I lost my job. I see also my family and my friends dying because of COVID, and I was feeling very powerless. Then I found this collective Si Se Puede, and I got inscribed in order to find a new opportunity. So what I want to say is that you need to guarantee our families having access to health services, and also to teach our children how to go to the doctor if they need to, and also our family members to have access to health. Thank you.
And that concludes our request to speak.
Thank you very much to the clerk. Thank you to all who took time to speak. And if we could ask our translator to express thanks briefly to all who took time to speak in Spanish, that would be appropriate at this time.
Muchas gracias a todos por hablar. Les agradecemos a todos por poder expresar su opinión.
Thank you very much. All right, that brings the matter back to our board supervisor, or to our committee, forgive me, Supervisor Lee, and I'm just going to make a brief statement and perhaps somewhat uncharacteristically offer a motion and ask you for a second. I will have some questions as well. I'm going to begin with the motion, which is to forward to our board with a favorable recommendation, option number 3, which is the 400% of the poverty limit. And if I can get a second, I'll speak to that.
Absolutely supporting that second.
Thank you, Supervisor. Mr. Santiago and Ms. Rosas and others, you will recall this is an issue that I've been working on now for a number of years, talked about the importance of expanding healthcare coverage in my State of the County remarks back in, I think, February of 2019. The PCAP program is an important part of that. It has had its struggles. There's no shame in saying that. That's quite the opposite. We, I think, have learned an awful lot from the effort to date, as well as covering a lot of folks who otherwise would have been without services. That said, credit where credit is due. Thank you to the staff for really drawing this up, putting it together, implementing it, making it happen. Easy enough for any or all of us on the board to have a bright idea on any given Tuesday, but takes a whole lot more to actually make it real. So thank you for that. And again, while folks have appropriately, in my view, identified some of the limitations of the program to date, the fact that we've had the program in place and that you all have put it through its paces, so to speak, means we are now, I think, very well positioned to say, we know where we can strengthen the program. We know how to do that. And I think that's what we are poised to do. The issue of 200%, 300%, 400%, I think I would frame this way. And first, I would say we're fortunate in this county that probably 94 or 95% of the population is covered. And that sounds like an awfully good number, and in many respects it is. But 5% is not an inconsequential number in a county of this size. That means there are probably 100,000 folks out there who are going without coverage on any given day and may or may not be able to access the services that they need for a healthy life. So, if we can step up and help serve some significant portion of that 100,000, I think that is a worthy effort indeed. Ms. Rosas, I heard you loud and clear when you said that 30,000 number might or might not turn out to be 30,000, and that it might take some time to get there. I think, and this is a little counterintuitive, but I think the 30,000 number, the fact that it is challenging to get to that number is in part a function of the fact that if we can pull these people into the system, we have the ability then to say, look, here are half a dozen insurance options that you might be eligible for, and get them into one of those insurance programs. So I'm thinking of Medi-Cal, I'm thinking of Medicare, I'm thinking of Covered California. So I see one of the benefits of expanding the eligibility to 400% as providing us with an opportunity to pull more folks into the conversation about here's how you can be covered, here's how you can get the health care that you need. And I think they may never show up on our numbers for PCAP, but that my hope and expectation is that there'll be significant ancillary beneficiaries. And then finally, I would say in our costly valley, 400% of the poverty limit hardly makes you a prosperous household. And I have expressed concern over the years, which I not only continue to have, but which if anything is growing, is that our systems nationally, state and county too often miss what I call the missing middle. It's a term that's been referred to or used in the housing arena, I know, but it refers to a group of folks who are doing just a little too well to qualify for some of our programs, but not well enough to fend for themselves in a tough healthcare market or housing market, whatever the context may be. So I see the 400% as helping us get to a significant number of folks who otherwise would go without the coverage or the services that they require. It gets us into a conversation with folks who we can move towards other health insurance products, and it helps us address a cohort of the population that may be sort of just hanging on. Maybe they're doing seasonal work, but that is far from prosperous by any reasonable definition in our valley. And it does all that for a relatively manageable cost. I don't mean to dismiss $15 million, but given if I'm looking at the return on investment here, I think that is a very reasonable investment to make if we can in fact cover as many folks at that cost as the numbers indicate. So for all those reasons, I'm very enthusiastic. I will move to approve. We've got a second from Supervisor Lee, and I'm going to let him get a word in edgewise now. I do have a couple of questions after we hear from Supervisor Lee, so please hang in with us before we take the vote.
Yes, I truly believe that the so-called federal property levels a number that certainly does not apply to the Silicon Valley. So that's why the 400% of the FPL is still really not a huge number by any stretch of imagination, even though it sounds like it is. So this missing middle, as Supervisor Sumitian has just mentioned, is something that we really need to help cover. And I'm very glad that we're moving to that direction. Now, I would like to thank the community that came out to speak on this item, as we know the importance this will make to the community, and I will speak that in Spanish as well. Gracias la comunidad hoy por hablar sobre este tema. Sabemos lo importante que será para la comunidad. Muchísimas gracias. Thank you so much. That's all I have.
Thank you, Supervisor Lee. And let me just ask a couple of questions. Ms. Rosas, there was passing mention of revisiting the payment structure for our community providers. I know, to put it bluntly, that part of the challenge has been that our community clinics have not found the reimbursement structure we have particularly robust, in their view at least. What are your thoughts about, and since this is a program that relies on people to provide services, we got to make sure that they are incentivized to provide services, or at least stable enough to provide the services. What are your thoughts about doing better in that regard? And I'll go to you.
Sure. Thank you, Supervisor. We think that the inclusion of more quality dollars will make a difference, in addition to the $12 per member per month, as well as the $50 for the recertification work that would happen every year. But we are happy to work with them over the course of 2022 as a calendar year, and look at other methods of reimbursing. For example, run it on a fee for service and see what the numbers look like. And we can bring that back to this board as well when we do that.
Okay, and when I looked at your timeline, and I may have simply misunderstood or not been fully familiar with a couple of terms of art, I thought that discussion was deferred until 2023, which is in part what prompted the question, because I'm hoping we can get to this very important part of the conversation sooner rather than later, meaning 2022. Did I read the chart correctly?
Yeah, so we're really, I think for 2022, we're trying to stabilize the program. We can start exploring sometime, I would say this summer, on running some of these numbers and really exploring. We've got a lot of work to do up front. I think the value-based program is going to, be a lift, but we can absolutely start working on that through 2022 and start working on some additional options for reimbursement. But I think it would be also a good idea to see how this works with the quality program and the recertification dollars as well.
I think what I'd like to do, Supervisor Lee, if you're willing to accept this as the seconder of the motion, is provide direction that those reimbursement issues be addressed explicitly in 2022, so that by the time we hit 2023, you know, I know the board can't direct success, but that our hope and expectation is that those reimbursement issues will be resolved and that a new model will be in place beginning with calendar 2023. Supervisor Lee, can I get a second on that revised motion as well?
Happy to second. Thank you.
All right. And Ms. Rosas, yes, I know as I look at your face that I've just pushed more work for you into 2022. But I really do think, as I say, that the success of this effort will in part depend on having partners who feel like they can embrace the model, and that if they do, it won't be to their financial detriment. And so I want to see that conversation and resolution of that conversation sooner rather than later. If there's any way on earth we can make that happen. So that's why the direction would be there. Let me also ask, and I don't know if this goes to you or Mr. Santiago, either one of you can and will lean in. Funding source, what's your thought about the necessity of identifying a funding source given the dollar amount we're talking about at 400%?
Yes, and Laura and I had the privilege of talking to Dr. Smith before this meeting, and he's committed to making this program work on that particular model. So I wanted to express that on his behalf, and of course we'll figure it out in terms of the funding. So that should not be a worry for any of our stakeholders.
All right. I don't think we need formal direction, Mr. Santiago, but then do I correctly infer from your comments that the administration would look to identify a funding source as part of the budget exercise, both in the mid-year and the June budget exercise?
Correct.
Okay. And timing on when this 400% model could take effect if it receives support from the full board?
I mean, I think we can get back to in a certain date. I don't think it would be that difficult to increase it.
Can we ask you, when you report back to our board, when we come with this favorable recommendation, to bring a proposed implementation date for consideration and action and discussion at that time? All right. So understand that you can't pick a day out of thin air today, but if you could find a date that you think is practicable to meet when we take this up as a board, I think that would be helpful. Good. All right. I think I have no further questions. Supervisor Lee, still good to go? All right. We have a motion by Simidian and a second by Supervisor Lee, and a thank you from all to staff for having brought us this far and being willing to take this next big step, which I really do think is the next big step. Let's call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. All right, motion carries unanimously. Thanks again. That takes us to item number 9. And we're looking only at 9A today because 9B and C were placed on consent. So I think I go to Ms. Terrell for this one, yes?
Yes, good afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell with Behavioral Health Services Department. We will have a brief report provided by Mego Lien, our Prevention Services Division Manager, and this is our Suicide Prevention Program Fiscal Year 21 Annual Report.
Hi, is my slide sharing?
Yes, we can see it, Mego. Thank you.
Great. Okay, thank you. All right, good afternoon. This reporting period covers FY21 with inclusion of some updated data on suicide in the county from the past few months. Just as a reminder, the suicide prevention program in the county works towards these 5 outcomes objectives that you see on this blue pyramid in the middle of the screen. And these address risk and protective factors for suicide. In terms of the county number of suicide deaths, we have been seeing a general increase over the past 5 years in both the suicide count and the rate. And this increase that I reported on last year in 2019 to 169 deaths, that was an increase that we saw sustained in our early numbers in 2020 with 164 deaths. The red asterisk on top of the 2020 is because the 2020 US Census population data is not yet available, so we don't have that number to calculate the rate.
Ms. Leanne, excuse the interruption. I try not to throw you off your rhythm here, but does that mean that while we don't have the ability to calculate the rate, that we are clear that 164 is the correct number for 2020?
Yes, we get those numbers from the coroner's office. So
Thank you.
that is confirmed.
Thank you very much.
In terms of the increase in 2019 and 2020, here are some observations about the increase. We saw a slight increase in suicides among females as well as males, although males are still the predominant gender in suicides, both the county and nationally. In the age groups 25 to 34 and in our older adult age groups, we did see some increases, although we did see an encouraging second consecutive year of decrease among our 15 to 24 age group. The increases were pretty consistent across racial ethnic groups. And then the methods of suicides by hanging as well as overdose, particularly by prescription medication, were contributing to this increase as well. We did a little further data analysis and found top stressors in these suicides were mental health, physical health conditions, followed by relationships, so intimate partner conflicts. And this was based on a review of the coroner death reports. In terms of youth suicide prevention, our school-based partnership was in its third year. We engaged with 3 additional school districts in suicide prevention. And with the pandemic and shelter in place, we did see a large increase in the use of the Cognito online training modules by school districts and students. With the Youth Connectedness Initiative in Palo Alto under YCS, we did a lot of work on evaluating their program and looking at outcomes on belongingness and connection among the youth, especially among the youth peer leaders who participate in YCI. And we also focused on expanding the program in terms of funding sources and to other cities, especially Mountain View. The program ran 2 suicide prevention public awareness campaigns last fiscal year. The one on the right that you see here was in direct response to the COVID pandemic. And we had a focus on Vietnamese and Spanish speaking communities in addition to English. We also began evaluating these campaigns in more detail last year, and we saw some significant effects in terms of increasing knowledge about warning signs, increasing knowledge about resources like the Suicide Lifeline, and increased willingness to seek help. And this is when we compared responses from people who said they saw the campaigns versus those who said they did not see the campaigns. Last year, we also began this initiative through partnership with Palo Alto University, and this was initiating work within the health system to assess and enhance suicide services, especially within primary care and behavioral health, the 2 systems. The main partnerships that were formed last year were with primary care behavioral health and with Momentum on the behavioral health side. And the training and consultation efforts with both these entities are continuing this fiscal year. So in terms of future directions, as always, we would like to sustain and grow these current efforts, particularly the evaluation and data-driven approaches. We are working to address some of the 2019 data recommendations, particularly exploring suicide prevention efforts with workplaces to address that 25 to 34-year age group, as well as piloting our hangings means restriction strategies, because now in the county, suicides by ligature or hanging has become the predominant method. And there's a lot less research out there about how to restrict means for hangings. The suicide prevention program has been brought under the prevention division with substance use prevention. And so we're looking at implementing joint efforts. There's opportunities in addressing suicides by overdose and those prescription medications, for example, as well as primary prevention efforts like with youth and social emotional learning. And then, as always, we continue our pursuit and analysis of suicide data, and especially trying to get faster access to suicide attempt and ideation data for the county. So those are the highlights, and I can take questions.
Thank you. I do have a question, but let me go first to Supervisor Lee. Then I'll ask my question, and then we'll see if we have any members of the public who want to speak on this item. Thanks again, Ms. Leanne. Hang in there with us. Supervisor Lee?
Yes, thank you. Looking at the some of the data for the suicides, are there any type of general explanation you may be able to explain among these groups you mentioned, 25 to 34, 65, 74, or even 85 plus, going up, while those who are 15 to 24 age group actually has gone down?
Yeah, so in the field, we don't generally look at year-to-year counts. So for example, the suicides in the 15 to 24 age group, those rates represent a count of 4 deaths in 2018 to 19. And then there was an increase again by 3 deaths from 2019 to 2020. So because the numbers are so relatively low from a population standpoint, we really don't make trend recommendations, determinations, or really change our programming based on year to year. But that being said, with the decrease among the 15 to 24 age group, I think over the last 5 or so years, we have been seeing kind of a general deep downward trend, which has been encouraging. I mean, there's been a lot of focus in this county and statewide on youth mental health and suicide prevention. There's a number of policies. And we also started our suicide prevention school-based partnership 4 years ago. So we're hoping that that downward trend is an indication of all of that work having some effect.
Right. I mean, for what we have seen based on social media and also the type of pressure among the young people in other areas, it seems like you would expect that age group, the number would have been increasing. So the fact that instead of an increasing number being decreasing, I think that's certainly quite encouraging. And I hope that those services you mentioned that we've implemented has a effect to show that's the case. Now, under Objective 3, to reduce the access to lethal means, the report indicates that the County Suicide Prevention Oversight Committee has developed a gun safety suicide prevention public awareness campaign and disseminated the resources following the shooting at the VTA. Can you elaborate on the efforts regarding the VTA shooting as it relates to the public awareness campaign and any other efforts in progress being planned right now?
Sure. So a public awareness campaign on firearm safe storage. This is something we as a program had been talking about and wanting to put out there for a few years now. And so once the VTA shooting occurred, we really put the priority on getting that out there. So it's right now under development. The target launch date is November 29th, and it'll air for about 7 weeks. We're planning to have testimonials with 3 county residents who either have experience with firearm suicide and or gun ownership and can speak to the importance of safe storage. In addition to that, the program, we sit on the county's gun safety violence prevention team with the DA and public health and others. From what I understand, there's a gun buyback event being planned in Milpitas in December. So we always participate in those and give out suicide prevention resources to anyone who's relinquishing their firearms.
Great. Yeah, we're looking at probably December 11th, and I'm actually meeting the Milpitas police chief tomorrow on this very issue. So hopefully we will get some clarity in making sure that we have the funding and whatnot to make this a success after the November board meeting, if the funding get approved. So thank you for that. I have no questions for the call center report and improving access for service for the individuals on the JC list and those deemed incompetent to stand trial. But I would like to certainly thank the Behavioral Health Department for providing these thorough reports to HHC. And I know that the content on this report has been particularly heavy. I really want to acknowledge that BHSD for spending the time for the deep dive in these data, particularly on the number of individuals served, the waitlist numbers, and the wait times and all that. Thank you very, very much.
Apologies, Supervisor, you're on mute.
Oh, I think that's all I have. Thank you very much.
No, that was directed at me, and just so folks know, it's because the clerk keeps muting me and I don't realize I have been silenced by the clerk. So thank you.
Apologies. There's been some feedback.
That's all right. I will remember to unmute. Thank you. Just kidding. So Ms. Leanne, on the slides, if we go back, there's a reference to youth connectedness with the YCS program. And you mentioned that there was a effort underway to expand in Mountain View. Could you tell us a little bit more, since you've spent some time looking at the program, what you think the attributes are of the program that make it worthy? I think you know this is an effort that I championed as an inventory item originally several years ago, and I'm pleased to see that it's not only got traction, but is deemed worthy of sharing in other communities. What can you tell us about this particular program, since I have the benefit of your expertise on the call?
I think the hallmark of the program that kind of makes it stand out from other youth programs is the rooting of the programming in the Search Institute's developmental relationships framework. So there's been a whole bunch of research and work done by the Search Institute on what are those different aspects of developmental relationships, both from the youth side and from parents and adults in youth lives, that are supportive of better mental health, better education outcomes, et cetera. And we do know that the main protective factor for youth suicide, or really any suicide for any age, is connectedness to a trusted adult or another trusted person. And so being able to use that developmental relationships framework gives us some bit of confidence that we're doing things that are evidence-based through YCI. And in the evaluation that we started doing this year with the peer leaders, we are seeing some of those results. So this one right here on this slide, the blue are youth peer leaders, and the orange are responses from those who did not participate in YCI. And you can see there was much stronger disagreement in this statement that I have no sense of togetherness with my peers among YCI participants. So that was really encouraging to see.
Got it. And could you share a little bit more about the hopes or plans to expand the program across city boundaries?
Yes, so with bringing suicide prevention under the Prevention Services Division with substance use, there are a lot of other youth serving programs, but I think YCS and YCI in particular have strong connections in the North County area, and so can kind of help to fill that gap in the prevention services youth programming. They've been talking to City of Mountain View for a bit now. We've provided some trainings to City of Mountain View on suicide prevention. And I think there is some initial interest in trying to bring in some kind of YCI-like programming for Mountain View.
Great. All right, thank you very much. I have no other comments or questions. Let me check with the clerk to see if we have any speakers on this item.
I do have 2 requests.
Let's go ahead and hear from both of those folks, and we'll ask them, just by virtue of time, to limit their remarks to 1 minute today, please.
Thank you. Our first speaker is Vic. I've unmuted you. You'll have 1 minute to speak. Please go ahead.
Madam Clerk, it's pronounced Ojakian, not to worry.
Thank you very much.
Thank you, Supervisor Simidian. I just wanted to thank the supervisors, not just the 2 of you, the supervisors as a group, for helping sustain this program, because that's one of the things in suicide prevention that you learn quickly is some communities react to a death. They're not proactive and sustain programs over a period of time. And I think that's vital for our work, regardless of what short-term data shows. And I hope everybody reads the report, not just supervisors, and you'll see the extensive amount of programs and work that are going on that actually put us in a unique position as a county. Since I do work statewide, a lot of people ask about our programs. And some of our people, including MAGO, have presented its statewide webinars because people know how effective and the extent of the things we're doing. So thank you.
Thank you. Next speaker, please, Madam Clerk.
Our next speaker is Irvish. I've unmuted you. You'll have 1 minute to speak. Please go ahead. Irvish, please go ahead. Irvish, are you at your microphone? I'm assuming he has stepped away.
All right, Madam Clerk, then let's ask for a motion to receive the report from Supervisor Lee.
And so moved.
I will second. We'll call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously, and we will thank Mr. Rao and Ms. Lien and the entire team at Behavioral Health. Thank you all again. All right, that takes us on to item number 10, and that is a report from the Valley Health Plan relating to their operational report for 2021. And who do we turn to there?
Thank you. Sorry about that. Just trying to, thank you, Supervisor Simidian and Supervisor Lee. I'm going to share my screen. Can you see it? No, because I've hit share. One moment. You can see it now, right?
Yes.
We can.
Okay. Great. Thank you so much. And thank you for this opportunity to share our activities and our accomplishments over the past year or so. So I just wanted to speak a little bit about laying the foundation for what is our current success and our future successes. When we first entered 2020 and not realizing a pandemic was bearing down upon us, our focus was to upgrade our claim system, to really restructure medical management to industry standards, and to really grow our provider network, because that's really important to ensure that we're not only meeting our regulatory requirements, but that we can also provide care to all of our members. We were successful in upgrading the QNEX system. We were successful in expanding that network, which we'll talk about in a moment. And we were successful in the medical management piece. And I can talk a little bit about that later on. Medical management has really been transformed, and as is the case management team as well that we've added has been doing extraordinary work. And we'll talk about that in a moment. For 2021, our priorities were expansion, and we have been asked by Covered California to offer that plan to Region 9, which is San Benito, Monterey, and Santa Cruz counties, but really focusing on San Benito and Monterey. NCQA accreditation, which is a very rigorous accreditation and really the gold standard for health plans, is going to be required by Covered California and DHCS for Medi-Cal. So it is a must-have at this point. So that is a 2021 priority. And talent acquisition and staff retention. Given all of the work that we're doing, it's really critical to have the right people in the right positions. So on provider network growth, we have put a lot of effort into this and have really seen significant increases across all lines of business, especially in critical specialties like psychiatry, OBGYN, and orthopedic surgery. Also significant growth in primary care subspecialties such as internal medicine, pediatrics, and family practice. And you can see here where some of that growth is over the last 2 years. Again, as I said, Covered California did request that we enter that market, but it also means we had to adhere to all of the regulatory requirements to receive Department of Managed Healthcare approval. We did receive that approval after building a pretty decent network in Region 9 of 800 providers that we're currently credentialing. That was a substantial lift on the part of the Valley Health Plan team. And also we've received, so now we've covered California approval. So we are now officially in Region 9. We also contracted with these providers, not only for Covered California, but also for IFP and employee group. You know, many of our employees have moved to San Benito, especially the Hollister area, as well as we have employees in Monterey County. So having providers in those areas also makes the county employee option more attractive and more feasible. So we really see the Region 9 expansion as a win-win. and are really excited to be in Region 9 and are really gearing up for now the official open enrollment of Covered California November 1st. Switching gears a little bit, we talked in the last presentation around PCAP, around our performance improvement program. I won't spend so much time here, but just understand that it is also a requirement for NCQA. Covered California does want these sort of value-based payments as part of the program. So it's really important that we build that in now. And again, health equity is a big focus. A little bit more on accreditation. So we're currently accredited by AAHC, which is the Accreditation Association for Ambulatory Healthcare. Because of COVID, they have not been able to become on site. They did do a desk audit, which we passed, and they're coming next week finally. So we're excited, and we'll continue to work with AAHC while we prepare for NCQA accreditation. And here's our timeline, and according with some of the other things that have to happen. So in order to achieve NCQA, we really need some of the functionality that will be in Epic. For example, Epic provides us with a member portal and a provider portal. That's just a few examples. We also have population health is a really strong, robust part of that Epic tapestry build. So this just sort of shows you the look back periods and how we're coordinating the NCQA tapestry and focus and what some of the requirements are in terms of the health equity accreditation, for example, which is a separate accreditation from that NCQA provides, and that is going to be required by Covered California. Really focuses on things like having more languages and more of our communications in multiple languages than we have now. It has many, many aspects. It's a very rigorous accreditation requirement. So we're starting to work on that now. And again, that is in addition to the NCQA accreditation, although it is an NCQA initiative. I talked a little bit about our work in medical management. One of the really important additions to Valley Health Plan has been the case management team. So at the end of 2020, we had ended an expensive contract with a third-party case management vendor, and we only had a very small team in-house. Now we have a really significant team, about 18 FTEs, comprised of RNs, masters in social work, community health workers, and care coordinators that are providing complex case management and disease-focused case management, including biometric monitoring for our members. And we've also implemented a SET, which was an economical software solution for case management so that we could bring that in-house, and that would be a bridge solution until we implement Tapestry. So I think we're in a good position to take on the CalAIM work and all of the other work that's coming through both CalAIM and other initiatives at the state and federal level. And I can tell you that we really work with this team all the time. And it's just so great to be able to have that in-house and see what they're doing. It's really phenomenal. And just kudos to the case management team and the rest of the medical management team for all the work that they've done in the past year or so. So I've spoken about Epic. It will put all of our functionality onto one platform. It supports NCQ accreditation, and it really provides that interoperability with both our own health system as well as most of the Bay Area hospitals are on Epic, with only like 2 exceptions. So Epic is well represented in our region, and we think that's going to be a real help in a lot of the care coordination work we're doing. In addition, we're developing an electronic data warehouse, leveraging our own data and being able to make it available internally to VHP. So for example, it gives us great transparency into our provider network by zip code, by specialty. It will support our population health requirements, which are part of Covered California now, and really provides insights into so many of our operations and from provider network to pharmacy. So really excited about where that has gone as a project. I know, of course, none of this would be possible without the extraordinary team at VHP. And I just can't say enough about their efforts and their work over the last year or so. This has been a traumatic and unpredictable event for all of us. And throughout all of the last year and a half, they never stopped focusing on our initiatives, our priorities, ensuring that our providers were paid and that our members received care. We've had about 20 to 25 of our folks, about 20 are still out on as DSWs. We've done a lot of work around recognizing them and supporting them. And what we found over the last year and a half is how important communication is. It's almost like you cannot communicate enough. And I think both of you know that because you, again, are all in these communication roles. But we had monthly all staff meetings. We still do. We have a twice a week manager huddle. We have weekly all staff huddles. We have a question and answer session with our chief medical officer and medical director to answer questions about COVID, vaccines, the virus, new developments. And we've done a lot of work around employee wellness and engagement and ensuring that we have those connections even in a remote environment when we were all shelter in place. And now as we move back into the office, that we keep those engagements. And I think one of the outcomes of all of that communication, support, and engagement has been, this is a slide actually from our last all staff meeting, 100% compliance with county policy, but like 97 and 98% or more higher fully vaccinated. And I think that really, kudos to our clinical team and kudos to the BHP team for really bringing all these really difficult questions and concerns and a lot of the confusion that has really been at the beginning of this pandemic. Unfortunately, I think we did our level best to try to provide clear, unbiased, and accurate information around both COVID-19 and the vaccines. And I think, to me, this is a really great indicator that those efforts were well worth it and were heeded. So just wanted to share that. And then finally, this is just part of our employee wellness resources. As I said, we've done a lot of work, both tying our employees into the greater communications of the county to the wellness initiatives. We've engaged with EAP quite a lot over the last year, had them on our meetings, made sure that all of our employees were aware of what they offer and their services, which are really quite extensive considering what most employers offer. And then we have our own page and our own stellar wellness champions here who do all sorts of great outreach to our employees, especially during the pandemic when people were really just sort of hunkered down. We had virtual coffees and all sorts of virtual events to try to pull that team together. And I think the success we've had over the last year is really a reflection of those efforts. And just want to say that so proud to lead this team. They have done phenomenal work, and I know they will continue to be phenomenal in the future. And I'll just pause there and see if you have any questions. Thank you. I think you're on mute, Supervisor Smithian. Sorry.
Again, thank you. Ms. Rosas, let me just ask a couple quick questions here. One is, we have a communication, as you know, from the folks at the Santa Clara Family Health Plan about plans that are apparently underway. You're in conversation with a private provider for Medi-Cal managed care. And the email that I have, which I think came just yesterday afternoon from Ms. Tomkala, says, hope the public will have a chance to review and comment, wondering how and when such information will be available, encourage the county to be forthcoming with information as soon as possible, communicate the process and timeline. You know, now you'll know it's me. There's an on the one hand and on the other hand here. On the one hand, I understand that conversations with potential partners are likely to be part of a negotiation that's not ordinarily part of the public dialogue. On the other hand, if we have plans afoot to do things somewhat differently, I do think we're probably going to want to have an opportunity for both Supervisor Lee and myself as the committee members to talk with staff about that a bit, and also to sunshine it with the public, and to make sure that you all are in touch with both the family health plan, but also the other stakeholders who might either be affected or be concerned that they would be affected. Can we, I think what I'd like to suggest today, and I don't know if this is to you or Mr. Santiago, or both, but I think what I would suggest is that we ask you today to reach out to the family health plan and folks in the community health partnerships, our community clinic partners, just to talk with them about what you have in mind and what the potential issues there might be. And then in the meantime, I'll give some thought to how we might provide a venue either at the committee or the full board to have this conversation sooner rather than later, so that you don't get tangled up towards the end of the process with people saying, wait a minute, nobody talked to us, nobody asked us what we thought. Does that sound sensible to you?
Yes, Mr. Chair, I think it's very appropriate. And Laura has, well, I'm sure will be happy to do so. She's been having ongoing conversations to coordinate all the activities on our behalf with Family Health Plan, and she'll follow up. And we did talk about this with Dr. Smith, and of course he would like to also be involved in whether it be a special hearing or session that you want to focus. If you remember a while back, we looked at very in-depth having a unified managed care strategy for our county of Santa Clara. We were anticipating changes at the policy level that would kind of gear us towards this direction if we wanted to continue to provide more comprehensive and integrated care. And of course, as managed care plans are having to address social determinants of health and go beyond the scope, in some cases, even outside of our health systems, we have to coordinate with the housing office, we have to coordinate with social services, we have to coordinate with a variety of other county departments. So I think this is the direction that we're certainly under Dr. Smith. He's been giving us the charge to move towards and have these kind of relationships. But I think it does merit a focused conversation to make sure that our stakeholders are fully informed.
All right, great. Thank you for that. And let me just ask a question, Ms. Rosas, about the expansion into these other counties. Do I gather correctly that this was something that Covered California was encouraging because they were concerned there weren't enough choices in those counties for consumers in those counties?
That is correct.
Okay.
They did not see that there was enough choices. The other issue is that they see us as being a really great partner, frankly, being that we are also a government-owned plan, that we are not, obviously motivated by profit. So we have a good relationship with Covered California.
And you mentioned greater emphasis in all likelihood on San Benito and Monterey counties as contrasted with Santa Cruz County, even though the expansion effort would go there. I'm just curious why those two more and Santa Cruz somewhat less.
I think there's other options in Santa Cruz. I think San Benito and Monterey had more need.
Okay. And then I think it's, yes, page 6 of the staff report talks about the quality assurance, quality scores, commercial plan at 3 out of 5 star ranking, and Covered California recently downgrading us to 2 out of 5 stars. That doesn't sound like happy news to me. Should I be concerned?
No, I think, for this past year, because of COVID, we've not been able to work on our HEDIS scores or anything like that. NCQA, which owns HEDIS, had put everything on a pause because it's so difficult to get into doctors' offices, and obviously utilization had really dropped. So I think going forward now with our quality program and with hopefully COVID not quite in the rearview mirror, but certainly diminished, we can start this quality and ensure that our HEDIS scores go up. So I think it's been a bit of a pause on that, but that's true for all plans. And going forward, we should see an increase.
All right, well, I think in a moment when we get to a motion, I'll ask that we get an off-agenda report that provides a little bit more in the way of explanation to help us all understand what the dynamics were in connection with quality and strategic improvement team issues identified in page 6, and also what your thoughts are about how to both do better and be ranked higher. And I know sometimes you do better and don't get ranked higher. Sometimes you get ranked higher when you haven't even done better. But I think we'd like to see both, and a little more information about that would be helpful. Let me turn to Supervisor Lee, see if he's got comments or questions. Then we'll go to members of the public if there are folks who are queued up who would like to speak. And I will ask, if you would like to speak on this item, please raise your hand now so that we know how many we've got. Supervisor Lee, to you. Thank you, Ms. Rosas.
Yes, thank you, Ms. Rosas. Actually, I have no further comments. Thank you for the detailed report.
All right. Let me turn to the clerk then and say, do we have folks who want to speak on this item?
We do not. We do have one.
Just one?
Yes.
All right, let's go ahead and hear from that person. We'll give them a minute.
Our first speaker is Irvish. I've unmuted you. You'll have 1 minute to speak. Please go ahead.
Thank you very much to the Board of Supervisors, Supervisor Commission, and Supervisor Audley, and as well as the county staff. I want to specifically mention about the suicide prevention program that is being established for youth. In the same way, the suicide prevention program could be established for veterans as well. I'm ascertained that there is a Veterans Commission with the Santa Clara County. They could they could have emphasized more on that. How the suicide prevention program for the safe communities being helped out throughout the county of Santa Clara. However, within the jurisdiction of a county of Santa Clara, the VA hospital is only being available within the at the Palo Alto VA Care Center, and having said that how important this program could be, it would be important to include the veterans program as well, specifically as a part of a veterans outreach program for the suicide prevention. Thank you very much.
Thank you. Supervisor Lee, can we get a motion to receive the report with direction for an off-agenda report looking at these quality rating issues and laying out both an assessment of why they are what they are, but also a plan to push them up, and also direction to staff to reach out to relevant stakeholders at the earliest opportunity in connection with any plans to have VHP partner with a private sector participant in the Medi-Cal managed care program. And I was lip reading. I think that was so moved. Did I get it right?
That's right.
Thank you. And I'll second, and we'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you, Ms. Rosas. Thank you, Mr. Santiago. And Ms. Rosas, notwithstanding the questions, a lot of good work got done there. I do want to acknowledge that, and thank you for sharing it with us today. Okay.
Thank you, Supervisor Simidian.
Thank you. All right. Item number 11 was on our consent calendar. So that takes us then to item number 12. Let's see who we turn to for that report.
Supervisor Simidian, this is Jeff Draper here from the Facilities and Fleet Department.
Thanks, Mr. Draper. Go to it.
The project is moving well. We had a couple of challenges and we've overcome one of them. The latest challenge has to do with moment frame fabrication. We're working on solving that problem as well. So far, we think the project is on track, and I'll report something to you sooner than later if we find that it is not.
All right, thank you. Assuming that you stay on track, what's the first day you could open for business?
Oh, that's a little different question. I think we're trying to finish the project by the middle of December. It's probably about a month. Maybe we're trying to finish a little bit earlier, but it's probably about a month before we get through the licensing process. And so sometime between middle of December and January, middle of January.
All right. And I'm going to put Mr. Lorenz back into the conversation if he's still with us. I think he is. Mr. Lorenz, what's your thinking on this subject?
Supervisor, so if the facility is finished sometimes in December, I would anticipate that sometime in January, we would be ready from a programmatic and operations standpoint to open the facility.
Okay. And Mr. Lorenz, I am going to ask a question I've asked in the past, but candidly, I just can't remember the answer. And that is, what are the benefits of having a county pharmacy in this location? If somebody said, well, you know, I can already run over to Walgreens or CVS, what's the benefit to me of having a county pharmacy there? What's the answer to that question?
Well, there's three points that I would make. One is that, as you well know, we're partnering with Planned Parenthood. So we will make available to the entire community, including our community partners, the availability of pharmacy services. And as you well know, we did start a new program, MedAssist, that will also be available through that location, along with ongoing pharmacy accessibility for many of our low-income patients and our Medi-Cal patients. So it does provide for another avenue for accessibility, along with a partnership with the community health clinics.
Are there benefits to a low-income person using a county pharmacy that they wouldn't get at some other location?
Well, first of all, as you well know, we serve a large membership of Medi-Cal patients. We also serve a large number of uninsured individuals. So ease of accessibility is a major factor via our pharmacies.
And accessibility is meaning something as simple but basic as, you know, if somebody's getting their health care at Planned Parenthood and they don't have a car and they have to make their way on bus to 3 different stops, it actually matters a lot to them in terms of accessing their meds if the pharmacy is embedded in the same facility?
Absolutely. And as you well know, we're also opening up a specialty clinic there. So we will be rotating specialists through that location. Right. Pulmonology and cardiology are the 2 first specialties.
All right.
And we will also have other specialties rotating there as well.
Okay, thank you. Supervisor Lee, I'm going to see if we have anybody to speak on this item. Madam Clerk?
We do not.
Supervisor Lee, you ready to move to receive the report?
We'll move to receive the report, please. Thank you.
All right, I'll second. Call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simitian?
Aye. Motion carries. Thank you very much. That takes us, Mr. Lorenz, to the very MedAssist program that you were talking about, which is item 13. How are we doing?
Thank you, Supervisor. So I do have Dr. Nari Singh on the line with me, and he can answer specific questions regarding our report. But I would first say that we are making very good progress in meeting the deadline and timeline relative to the implementation. And in fact, we launched on October 4th. Nari, can you give some specifics and answer any questions?
Absolutely. Actually, good afternoon, Mr. Chairman Samitian and Supervisor Lee. We did launch the program on October the 4th, and our plan so far has been to make sure that the website is stable. The admin tool on the back end is being developed as we speak, and we have started our initial marketing. I think the Day on the Bay was our first place where we sent some information, and we got pretty good response from that. Our marketing team is working with all the social media outlets. We are planning on news media and radio to start the advertising for this particular program.
Thank you. Let me ask the first, I'm almost sure I know the answer. On page 3 of 4 in the staff report, very importantly, you mentioned that relevant forms will be available in multiple languages, including Spanish, Vietnamese, and Chinese, yes?
Correct.
I assume English is also one of the available languages.
That is correct. It is already available.
Thank you. Just wanted to be sure. Then on a somewhat more substantive note, since we last discussed the program, I gather there's the addition of one additional inclusion criteria or eligibility criteria, and that is that in addition to being an 18-year-old or older resident of Santa Clara County who has a valid prescription and a household income of less than 950% of the federal poverty level, there's now a criteria that requires that out-of-pocket healthcare expense in the prior calendar year is greater than 4% of the household income. Do I have that right? And could either you or Dr. Lorenz, or excuse me, Mr. Lorenz, or both say, where'd that come from? Why is that here now?
We actually have been trying to establish the program in a way where we believe that, number one, it would be similar to the programs that are out there. And second, the amount of funding that we are going to give back to the recipient has to meet the amount of time they're trying to spend in application. And when we were doing the calculations of how much funding we will be giving back to them, we believe that any expenditure less than 4%, the amount of time the person will spend in application, in providing the data and providing the information, may not be worth it for them to receive the amount of funding that they may receive. So that is where the thought process was, to have at least 4% of household income.
I'm going to ask Mr. Lorenz if I can get well, let me tell you my concern. My concern is that anytime we add another criteria, we make it more complicated. And anytime we make it more complicated, I worry that we reduce the inclination to participate in the program. And you all have done a marvelous job, and I really do appreciate it over the past year or so, of simplifying the program and the eligibility criteria and making it something that I really do think can and will work for people of modest means, including that missing middle that we talked about earlier today. I worry, as I say, that by adding yet another qualification, yet another criteria, yet another something that people have to prove in order to qualify, that it will be a disincentive to people. Can I ask you, Dr. Singh, and also you, Mr. Lorenz, and your mic is muted, by the way, Mr. Lorenz, to monitor this on a monthly basis, and even if it's anecdotal, be attentive to whether or not that 4% criteria appears to be an impediment to getting folks signed up and into the program.
Supervisor, your point is well taken relative to a criteria preventing individuals from qualifying or even applying. So we will monitor that closely. And we do have the flexibility, given your board's direction on this program, to make those changes as the program unfolds. So we will follow that very closely to ensure that it's not an impediment.
Thank you. That you read my mind, as you're getting pretty good at that after 8.5 years together, Mr. Lorenz. You read my mind, which was, I was just about to ask, if as you go, you find that it is an impediment, would you please just unilaterally make the judgment to jettison the requirement? If it turns out that it's not an impediment and that there is robust participation in the program, which there should be, it is a good program, it is a simple program, and it's one that is designed to help people who are trying to get life-saving medications without putting themselves in financial peril to a better place. I think if you have trouble getting folks to take advantage of a program that's this good, you got to ask yourself why. If it turns out that I am imagining a problem that does not exist, I will be delighted to learn that. But if it turns out that that problem does arise, I'm very pleased to hear that you'll monitor that and then just make the unilateral judgment about whether or not that's the cause of the problem, and if so, it should be scrapped. Okay?
Understood.
All right. Thank you very much. And again, thank you. I think we've come a long way over the last year to make this a really patient-friendly
process. Do I gather we're going to do a more formal launch probably end of February, beginning of March? Does that sound right, Mr. Lorenz?
That is correct.
All right. Well, I think you're wise, as always, to try and roll it out slowly, make sure you learn from your early experience and make the program ever better before the formal launch. And I'll say thank you again. Let me see if we have any questions from Supervisor Lee.
Yes, thank you. First of all, I want to thank you for coming out and your staff, Mr. Singh, on the day to start getting the outreach to the public, as we had close to, I think, 3,000 people coming out, residents that came out to the event. So I really do hope that the word gets out there for our community, make sure they receive information, increase their participation. Have there been any direct contacts with potential clients that would qualify coming directly from staff? Have you done that type of outreach as well?
We have done 2 focus groups, and we have shared the details of the program with both the focus groups. Okay. And we have gotten pretty good feedback from them, and we actually had to modify the program or the website a little based upon the feedback we have received from them.
So based on the feedback from focus group, then you're going to go get the large external outreach, right?
That's correct.
Okay, and this is really covering the missing middle, right? Regarding those high out-of-pocket costs, such as insulin, the asthma inhalers, the epinephrine auto-injectors, these very like life-saving, basically, items that's so important. I just wanted to make sure that we are going to do a really good job. I think people who are on these would really appreciate these programs. So getting the word out there, I think, is really the key. As soon as people find out, I think they will be jumping on to sign on this program if they qualified. So thank you so much for continuing doing that. Thank you. And that's all I have.
All right, let me check with the clerk to see if we have any speakers on this item.
We do not.
Then I'll ask Supervisor Lee for a motion to receive the report.
Yes, so moved.
Second by Simidian. Please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you very much. That takes us to item number 14. And that, of course, is our item where we ask for an update from the director. And let me turn to Mr. Santiago to sort of walk us through item 14A through H.
Yes, and good afternoon again. First of all, the departments have submitted written reports, so they're available for you. And in the interest of time, unless you have any questions for them, we'll go through them very quickly. The couple things that I wanted to highlight is in my report, I'm giving an update on the couple things, the usual coverage, health coverage, how we're doing in terms of Medi-Cal, as well as PCAP, as you heard earlier, as well as Cover California. We'll also give you an update on a matter that's been very important for the full board and want to make sure that you have a preview of that, and that is a board referral on the status of the universal behavioral health screening, how that's going. So my director's report gives you pretty much a snapshot of what we're going to be presenting, hopefully sometime in November, to the full board of supervisors based on the board referral that they wanted to find out our plan and our clinics and what activities we're currently doing to screen for mental health very early on for children and youth in our community. The other piece, we also have a comprehensive update in terms of the various bills that were signed by the governor. So that way you have that in front of you. And of course, later on today, we have an update on the federal level from Bert Bargolan. So not unless there's any questions about any specific issue or department, that will conclude our reports. And then obviously in the interest of time, you could go straight ahead into Bert Bargolan, so desired.
The only question, it's not a question, the only observation I would share or offer at this time is I know the number, but every time I see the number of folks who rely on Medi-Cal, I am reminded, I believe the number here is 405,000 folks at this point, as the slow but steady increase in enrollment has taken place. I just think, even in a county our size, that it's just, it's an extraordinary and, you know, arguably essential part of the safety net. I'm not sure for folks who have other forms of insurance, they have any reason to know just how essential Medi-Cal is to the health and well-being of our community. But, you know, we're talking about something better than 20% of our population. That's not a small thing. So I'll say just duly noted. And I did appreciate the list of legislative items that we are looking at. Very helpful to sort of have them all in one place as a way to sort of get a quick take on what's been happening at the state level. We will move on to Mr. Margolin here in a moment or two, but let me first check in and see if Supervisor Lee, do you have anything before we get to Mr. Margolin? All right, nothing from Supervisor Lee. Then let me ask the clerk, do we have any comment, anybody in the queue on this item?
We do not.
All right, then without any speakers, Mr. Margolin, we're going to give you the last word. And for once, we're not rushing you at 2 minutes before 5. So your trademark rapid fire delivery can go down a notch if you like. Thank you.
I appreciate that, Mr. Chair, Supervisors, good afternoon. Let me begin with a report. In fact, the thrust of the report today is really about the reconciliation negotiations, the effort by President Biden to get his major domestic agenda through. This package includes, as you know from our prior discussions, a number of very significant healthcare initiatives. The negotiations have been intense. There have been very sharp divisions between the moderates and the progressives on the Democratic side about what should be in the package. And for a while, the media has suggested this negotiation may be heading towards a bad end. But in the last day or two, the president has directly gotten involved, meetings in the White House yesterday and today. And what many of us predicted all along, which is that Democrats would have no choice but to come together, has begun to happen here. There are strong indications that we're moving rather rapidly towards a compromise. The president actually is pushing this deal forward by creating a new deadline. And there had other deadlines in the past. Speaker Pelosi had a deadline in September, which wasn't met, but the president is traveling to Glasgow at the end of this month for the UN Climate Change Conference, and he's telling senators, members of the House, he doesn't want to go to an international conference, a UN-sponsored conference, with the infrastructure bill, the hard infrastructure bill unpassed, and the reconciliation negotiations in seeming disarray. He wants to have clarity on both items before he leaves the country. And that argument, that deadline, which is somewhat arbitrary, because again, if he doesn't get this done by October 31, which is the date this conference starts in Glasgow, it doesn't mean we can't continue on through November, but the deadline he's created has accelerated matters somewhat. So the plan they're trying to work out is before he goes to the UN conference, he wants the House next week to pass the hard infrastructure bill, the $1.2 billion hard infrastructure bill. And then he wants all the parties to have agreed publicly to what is a framework for the reconciliation bill, the human infrastructure piece. This might involve a top line number as the major, so we know what the top line spending number is. It might be only that, but it's likely to be a top line number, as well as at least some sketching out of the key provisions. Now, on the top line number, we know the 3.5 trillion is off the table. Senator Manchin has put his number at 1.5 trillion. And what the president has done in the last day or so, he's basically said to House and Senate Democrats, listen, we have to cut this deal, and we're going to come in at close to 2 trillion. He'd like to make it 2 trillion plus, but the conventional wisdom now is that it will be something like 1.9 trillion, 1.75 trillion, somewhere in that area. The other piece of this debate, of course, has been, as discussed before, in order to get the number down to under 2 trillion, do you have fewer programs? That's one option. Or do you have the same number of programs funded for fewer years? And what's being leaked from these negotiations is they're likely to do probably a mixture of both, with the emphasis really being now on keeping as many programs as possible in the package and just funding them for fewer years. So no definitive word on where these issues are going to end, but here are reports over the last day on what's happening with healthcare issues we've been tracking. On the Affordable Care Act premium subsidy, the effort to sustain the subsidies passed in the earlier rescue package enacted this year that allow more money to go to more people in the form of premium subsidy, therefore more enrollment in the Affordable Care Act. The Democrats in the House and Senate were hoping to make this a permanent 10-year fix. Today, there are reports that the president may decide to make this only a 3-year fix in order to get the cost down. So again, there'll be a battle in 3 years on premium subsidies. On the Medicare expansion, which is supposed to include dental, vision, and hearing, the most controversial aspect of that has been the dental provision. And the president indicated over the last day that he may settle for a dental pilot program, not a full expansion, but something that would be called a pilot that would be more limited and last for fewer years. No word yet on how vision and hearing will be handled. Speaker Pelosi, prior to these latest negotiations, I think it was late last week, has said that she thinks that the drug pricing reform, one of the other big pieces of this package, is likely to not pass in its current form, and it'll be scaled back. We haven't gotten details yet on how far back it will be scaled, whether it'll involve fewer numbers of drugs per year, whether it'll involve reduced power by the secretary to negotiate for prices, for a better price with the pharmaceutical industry. But there will be a scale back in all likelihood on drug pricing reform. There are many other issues in the package, but to give you a sense as to what else that aren't directly health related, but to give you a sense as to how this negotiation is flowing, another example of what's being discussed now is not having the free community college program, but to scale back to some kind of enhanced subsidy for community college tuition, but no free guarantee any longer. Paid family leave. I'm sorry, Mr. Chair, do you have a question?
No, well, just I'm wondering what the pinging noise is that we're hearing in the back.
The pinging noise, you know what that is? I'm going to turn that off if I can.
Are you getting the latest updates from Washington even as we speak? Is that what's happening?
It's either from Washington or my son. I can't tell which unless I look at the actual device, which I'm not going to do. I'm hoping that's it's Washington. So appreciate you noting that, and I'll do my best to silence that, which in fact I haven't been able to do. Have I? So how does one silence this? I'm going to figure out a way to do that. If I only knew how, I would do it quickly. In any event,
no worries, no worries.
Okay,
we'll forge ahead through the pings.
Forge ahead. Just assume that it's like urgent news from Washington. We'll make that assumption. So free community college, restricted paid family leave. Was it 12 weeks? It might be a fewer number of weeks. Things like that are being negotiated. Some additional items to note involving healthcare. House staffers last week suggested that the Hill-Burton funding we talked about in past meetings, dollars for hospital infrastructure, which was previously pegged at $10 billion, will be lucky to survive at half that amount, at $5 billion. An example of the kind of chopping that's going to go on to get this price tag down. Another development worth noting here is that the Congressional Budget Office came out with a report just yesterday saying that if the Affordable Care Act subsidies and Medicaid expansions are in fact contained in the final version of this bill, the number of uninsured people, the net reduction in uninsured people will be something on the order of 4 million nationally. 4 million people who will have health insurance who previously wouldn't have had health insurance. So those are the highlights here. The negotiations intensifying. Happy to respond to questions you might have.
I have just a couple. One is, I think it may be the first time I've ever heard the word controversial and dental in the same sentence. What makes dental, Medicare dental services, quote, controversial?
Excellent question, because I actually had the same reaction when I first learned that it was, quote unquote, controversial. The National Dental Association, the American Dental Association, representing dentists, has expressed concern about this provision, as have other dental groups, because it has the potential to reduce the income that dentists will receive. You right now have people in of Medicare age who don't have dental coverage and who pay for it directly, or who buy private health insurance, private plans to cover their insurance. And they're worried, the Dental Association, that dentists nationally, that in order to fit this into the Medicare program, they'll end up with a lower reimbursement rate. So it's made that controversial in the dentist community. I'm sure not all dentists have that view. Some dentists are quite happy to welcome this, but there's been a concern about dentists losing revenue.
Okay. And then on the infrastructure funding, excuse me, for the hospital infrastructure funding, Mr. Margual, you know, I never thought I'd say this, but $5 billion isn't a heck of a lot of money when it comes to hospital funding.
Yes. Well, 10 billion was not a heck of a lot to begin with. And to chop it to 5, it becomes a gesture or a symbol more than a robust program. So I mention that because when you go from 3.5 trillion down to 1.9, there are losers in that calculation. Now the other strategy here could be to zero that out and say that we're going to revisit Hill-Burton on another day, that 5 billion does not really address the issue. We'll fight over this issue on another day, but it's not something that, I mean, right now, there's a chance that it will survive at that lower amount. And again, it won't be that meaningful an amount if you play that out nationally over multiple years.
Yes, and I guess given that modest amount, if it survives, do we know how folks would access those funds? Is it a competitive grant program? Is it?
Yes.
I mean, because it's really, that's, you know, that's probably, I mean, this is sort of my back of the envelope. Please tell me if you've got a different one, but you know, that's not enough to do one project in 50 states, each of 50 states. That's, you know.
So Supervisor Lee actually raised the issue of whether or not our behavioral health facility here in Santa Clara County would be eligible for this. And we've since learned that in fact, it would technically be eligible, but it's not a lot of money. It will be competitive, and there's going to be a lot of discretion given to the Secretary of Health and Human Services to recreate this program. Hill-Burton was originally a program created in 1947. It got defunded about 20 years ago in an effort to revive it. What the bill does say is that the projects that will get preference here are projects that fund that are designed to deal with public health emergency preparedness, national disaster emergency preparedness, or cybersecurity. So there is some language in the bill that gives priority to certain categories of projects, but again, the final program will be developed by the Secretary.
Thank you. And I'll turn to Supervisor Lee to see if he's got comments or questions before we let you go.
Thank you.
Yes, thank you very much, Ms. McGowan. Try to understand the horse trading we're dealing with in DC is never easy. So it sounds like the president has now demanded that the House to pass the 1.2 trillion infrastructure bill, which by the way is bipartisan, of 69 senators voted yes, which means there are 19 Republicans, right? So basically said, go ahead and pass this while we are still messing around with the reconciliation bill. The one that's anywhere between 1.5 to 3.5 trillion, maybe 2 is the number at the end, but that's where all the sausage making is doing. I'm not going to go into any further details, as I don't think none of us really know anything what's going on at this point. But so it sounded like instead of having the two bills together, as has always been talked about, the president's not willing to get the infrastructure bill out of the way first, right?
He is, with this one qualification. He wants the Senate Democrats, who are the key to reconciliation passing, to commit to a framework and what that means. So he wants there to be a commitment to a number and probably some level of program detail, because you're not going to get House progressives to vote for that infrastructure bill without some commitment by Senator Manchin, Senator Sinema in particular, to a funding level and some level of detail. And again, how much they're negotiating as we speak, but it has to be more. He knows they can't get the reconciliation bill pass that quickly. That's impossible. And he does want, this is a change, the hard infrastructure, which is bipartisan, to pass first, if that can be worked out. But there has to be some level of commitment. It can't be, we'll talk to you tomorrow, trust us.
Yeah, as we know, without deadline, things don't happen. And so I see it looks like it's trying to at least put something on the scoreboard. In this case,
yes.
I guess this is like a field goal with the infrastructure bill before we try to home run for the reconciliation bill in the football analogy. Now, the drug pricing plan, you said it won't pass in current form to be scaled back. What's the holdback on this one? It's just basically pharmaceutical companies fighting really hard, lobbying.
The pharmaceutical companies who are a very influential lobby in Washington are fighting very, very, very hard. They put together a group of House Democrats, you may recall, we reported on this a month or so back, who sent a letter to Speaker Pelosi saying they wouldn't vote for the drug pricing provision as it was written at that time. And she only has a 3-vote margin, and 7 or 8 House Democrats can scuttle that. And there are individual senators who've made similar comments. So they don't have the votes for the full package. What Speaker Pelosi is trying to do is get as much as she can. And that's an internal negotiation that we don't have much visibility into right now. It'll just be a smaller package. We do know that.
Right. You mentioned they are going to scale back the community college program. I did hear that they're going to do 2 more years of preschool. Is that one still in good shape or no?
The preschool piece is in good shape. At this point, based upon current, community college scaled back substantially. Universal pre-K. Senator Manchin apparently is a strong supporter of that.
Oh, good.
So again, his influence counts for a lot here, and I think it's in pretty good shape.
He must have some grandkids.
He may very well.
All right. Now, you mentioned about the hospital funding. The 10 billion might now be down to 5 billion.
Yes.
But the good news is some of that is qualified for our, in case we're going to build our mental health facility. This is something we could use.
Possibly. I wanted to qualify. It isn't because the secretary will set up the actual details of the program, and the secretary may structure it so that we don't qualify. But I wanted to tell you that it's an open issue. It's possible that what you asked could come to pass. It is possible.
Right. And then my last question is regarding the CBO estimates. They're saying that the additional number of uninsured being covered will be close to 4 million people.
Yeah, a net increase of 4 million. And the way it actually works is actually going to cover about 7 or 8 million people, but about 3 or 4 million are people who currently have private health insurance who will move over, and they talk about them. So, but the net will be about 4 million.
And those are the ones who have the probably like crappy plan.
Yeah, very bad plans. Exactly.
To the good ACA plan. So
exactly.
It's not just 4 million more, but really 7, 8 million people will be affected. Getting out these lousy plans. Okay, that's great to know. Thank you very much. Yeah,
you're correct.
All right, thank you all very much. I think that is the last of our presenters and the last of our questions and comments. We had no members of the public wishing to speak on this item, so
I do have one request since Mr. Margolin has started speaking.
All right, we'll take it, but 1 minute, please, and that will be it. And again, folks, when we ask at the front end, we would appreciate it if you can sign in on a timely basis. Thank you so much.
Our speaker is Irvish. I've unmuted you. You'll have 1 minute to speak. Please go ahead.
Sure. Thank you very much for the consideration to as a public speaker for the comments. I want to mention to the Board of Supervisors with regards to what is transpiring with the U.S. Treasury specifically. Recently, the U.S. Treasury is amending a plan to track more American bank accounts to limit the tax evasion, as it is being known that that the proposals are being made for the finance industries as well as the conservatives to provide a proposal where Internal Revenue Service will provide new policies and information on U.S. bank account for the higher amount and the wealthy people to provide more taxes in order to elude taxes for the progressive work through the IRS and as well as the tax money to work through the government. So just wanted to have comments on that and as well as the audits for the families making more than 400K. Thank you very much.
Thank you. That concludes our requests.
Thank you, Madam Clerk. And we'll ask Supervisor Lee for a motion to receive the report.
Yes, Chair, so moved.
And I will second. We'll call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simidian,
Aye. The motion is carried unanimously. We will thank all of you for a very productive meeting today. Thank all of you on this last item, including but not limited to Mr. Margolin. And Mr. Margolin, we hope there's good news from Washington to accompany all that musical background. Take care. We are adjourned.
Recording stopped.